And gentlemen, welcome to ISCDS and ICIN. I'm Kavya and I will be anchoring this program. ISCDS and ICIN will be held for 2 days, that is today and tomorrow. The morning event for this symposium will include introduction followed by clinical review session on stroke cerebrovascular diseases. This scientific session will follow the lunch. Well, we all have workshop scheduled for by a poster session and evening activities. At this time, I welcome Dr. Nabil Herial, who will introduce the chief scientific advisors for this symposium period.
Welcome to ISCDS and ICIN. Welcome to Hyderabad. Welcome to India. We are delighted and honored to have you all here and hope you enjoy the program we have planned for you. This symposium is designed to include a program that benefits all, from trainees to experienced practitioners to non-neurologists to neurologists. This event represents an international organizing effort with excellent cooperation from local physicians, irrespective of their affiliations and associations. This symposium is planned to increase awareness of stroke and share the latest scientific knowledge on stroke and cerebrovascular diseases, and to also join forces to address the rising global burden of stroke. The gathering today provides an opportunity to meet and hear from distinguished experts, national and international. And these individuals are experts in their own fields. We hope that the knowledge you gain and share today and tomorrow will be used to help improve the human condition throughout the world. I would like to start the program by inviting three individuals who are serving as the chief scientific advisors for this event. I would like to start with our first scientific advisor. This person would not need an introduction. He is already known to many people who haven't met him yet, and he is none other than Dr. Adnan Qureshi. I would like everybody to please welcome him to Hyderabad, welcome him to India. And Dr. Adnan Qureshi, sir, please. From New York. He was a visiting scientist at the Centers for Disease Control and Prevention in Atlanta, Georgia. He did his residency in neurology from the prestigious Emory University. He did his fellowship in neurocritical care from the prestigious Johns Hopkins University, and then a fellowship from the world's endovascular hub, the Milford Fillmore Hospital in Buffalo, New York. And then he is a professor of radiology, neurology, and neurosurgery at the University of Minnesota. Please, again, welcome Dr. Adnan Qureshi. He is an international expert and an acknowledged leader in stroke care and research. He is a pioneer who has added several clinical concepts and phenomena in fields of neurology, neurosurgery, radiology, interventional neurology, and critical care medicine. He is an accomplished researcher with over 500 scientific publications in prestigious journals that range from New England Journal of Medicine, Lancet, Archives of Internal Medicine, Critical Care Medicine, Neurology, Stroke, Circulation, etc. He has served as an invited speaker at numerous international forums and was a visiting professor at several universities in the United States and abroad. And it would probably take me the whole day if I start reading his CV. So I'll stop at that point. The next person is a senior neurologist and very well respected, Dr. J.M.K. Murthy, Professor J.M.K. Murthy, I apologize. Sir, please, can I have, yep. Professor Murthy right now is serving as the Chief of Neurology at the CARE hospitals locally here in Hyderabad. Absolutely. Journals. He has edited 2 books, 6 monographs, and contributed chapters to several textbooks, including the Handbook of Clinical Neurology. He has been a past editor of Neurology India and the editorial board of several journals, including Neurocritical Care and JAPI. He is a member of several professional bodies and recipient of several awards, including the famous Dr. A.B. Baker Distinguished Award from the American Academy of Neurology. He has been a professor in the past of the Usmania Medical College. He has been a professor in the past of NIMS and also the head of the Department of Neurology at NIMS. The third person, last but never the least, Professor Kaul. Please, sir. Professor Kaul is another fine senior neurologist who has held several senior positions nationally. He has obtained his DM Neurology from the famous JIPMER, Chandigarh in India. He underwent stroke fellowship at the National Institute of Health in United States of America from the University of Maryland. And he is a fellow of the American Stroke Association, fellow of the American Academy of Neurology, fellow of Royal College of Physicians. He has many publications on stroke in peer-reviewed journals. He is at present the head Department of Neurology and the dean at the Nizam's Institute of Medical Sciences, Hyderabad, India. Professor Kaul is the past president of the Indian Stroke Association, past president of the AP Neuroscientists Association, and is the current president of Indian Academy of Neurology. Ladies and gentlemen, the 3 experts. So at this point, after several minutes delay, but I promise we'll catch up. There's a lot of time for us to do that. And I will start the session, which is a clinical review session that lasts until lunch. This is designed for trainees, postgraduates, non-neurologists to just know more about stroke and cerebrovascular diseases in general. I would like to welcome Professor Subhash Kaul to start the sessions and our conference. Thank you so much.
Morning, respected chairpersons. Thank you very much for the organizers, particularly Nabil, for inviting me here. In our Indian conferences, usually in the beginning there are less people, and in the end also there are less people. It's only during the peak that you have more people, so that's very familiar. I'll be talking mainly about the clinical approach to stroke, and some of you are physicians and non-neurologists, and some of you are students also. Stroke is basically a focal or global neurological deficit, but usually it is focal. That's the stamp. So that's when we have to make diagnosis, we must look for focality of vascular origin. That is the definition. So for the diagnosis, we must ask for this suddenness and focalness. So therefore, history from the patient and eyewitness is important. When exactly did the event occur? So that we can pinpoint that it is really sudden. What was the patient doing at that time? Again, for making it more fine, not that to be missing anything. And then what was the event? Event can be usually limb weakness, facial weakness, sensory deficit, dysarthria, aphasia, visual loss, imbalance, vertigo, and rarely unconsciousness. And any of them can occur alone or they can occur in combination. So if they occur suddenly, we have to consider stroke. Particularly if the patient has a risk factor. You know, stroke is a result of risk factors. I remember Dr. Murthy, he is also my mentor. He used to say it is not a cerebrovascular accident. He would really hold us to task. It is something for which one has made preparations for 3 decades, 30 years, and then it's a culmination of that. And these are those risk factors: previous stroke, hypertension, ischemic heart disease, diabetes, fibrillation, smoking, raised cholesterol. So on this background, any sudden and focal deficit, consider stroke. But these are the red flags, which means if we have them, we should make sure that we are not missing something else. For instance, focal seizure with a Todd's palsy can mimic a stroke. If there is a sweating palpitation, think if it is hypoglycemia. If there is a severe headache, is it something else? Does he have an underlying tumor or any other aneurysm? Or if it is non-focal, again, question it. If there is an accompanying fever, or if the findings are inconsistent. So these are red flags. So here one must be careful that is it really a stroke? Because stroke mimics are common. In fact, if you look at the guidelines of American Heart Association, in the emergent abscess, but the last 4 will be detected by imaging, but the first 4 even imaging may not help. So therefore stroke still is a very, very clinical diagnosis, to be very sure. Now, in a suspected stroke, this is the general examination. You must look for all the peripheral pulses, xanthelasmas, auscultation of the heart to detect any murmur, bruise in the carotids. Fundus examination is very important. If in a stroke patient you find papilledema, absence of pulses in various extremities may mean cardiac emboli. Absence in lower limbs will give you the first clue to the coarctation. It may also suggest peripheral vascular disease. And one of our teachers used to say that when you check the pulse in the lower limbs, the patients and attendants appreciate that you are touching the feet of the patient. That is the added advantage. Neurological examination, basically our idea is to, when we see a stroke, we want to make a general impression that is this stroke hemispherical, that means affecting one side of the brain, is it brainstem, is it cerebellar, that is one line. And second thing, is it cortical or is it subcortical? So that impression we have to make even before we have gone to imaging, and that has to be done clinically. I think I'm still in this. Yeah. Okay. So you can see that the upper part, it's the cortex, and below the cortex, this is the subcortex, and then this is the brain stem, and then cerebral hemispheres on both sides. Based on clinical examination, we make a mental impression that I think this is what the patient has, and then confirm it with imaging. Now, cortical lesions. The signature of cortical lesions is that they cause cortical deficits, and the common cortical deficits are language, vision, and neglect, and we should look for them. Now, if the patient has a pure cortical damage and no subcortical involvement, then on the left side, you will get aphasia. That's more common. Then visual field cuts, and the motor deficit are usually small in the cortical, if it's a pure cortical problem. On the right side, obviously we don't get aphasia, but we get hemispatial neglect. Visual field cut will happen on right side also. And once again, pure cortical deficits don't cause usually dense deficits. They cause mini or small or very focal motor deficits. Now, aphasia, 2 types of aphasias. Motor, where patient cannot speak, but he can understand. And sensory, patient cannot understand, but he can speak, often without meaning. So therefore, it's called jargon aphasia. I will show you examples of both. But again, the recent research has shown that there are no watertight compartments between them. Sometimes in pure motor aphasias, you may have some elements of sensory aphasia also, and sometimes in sensory aphasia, you may have little elements of motor. But for understanding, these are the compartments which we generally make. Aphasias can be mixed, they can be partial, they can be in the recovering phase. So therefore, a motor aphasia may not be able to say 8 things out of 10, but 1 or 2 things he may say, like that. So we'll try to see this if it comes. No, I think the videos will not work, so forget about it. Now, as far as hemi-neglect is concerned, it goes mostly unnoticed. Because unlike aphasia, here the patient will not complain of anything in attendance sometimes, so goes mostly unnoticed. But the thing is that patient ignores one side of the space. Okay, like you can see here in this still, that usually when the neglected patient, you can, particularly if they are drowsy and all, just by looking at them, you can say this patient is avoiding or neglecting one side of his space, as you can see in this patient. Now, there are other methods to detect hemi-neglect if the patient is a little more conscious and cooperative, like double simultaneous stimulation. You give him stimuli on both sides, and when you simultaneously give it on one side, he neglects. And if the patient is more conscious and cooperative, then you can also detect it by tests on paper. Like you can see here, clock drawing is a very useful test. You can see he has drawn, this is a normal clock, but a patient with neglect will totally neglect one side of it and will, can be detected objectively by this clock drawing test, which is very useful. But obviously, in a obtended, severely sick patient, you cannot do these tests. They are only when the patient is better. But visual field cut is something which all of us who see the stroke must look for. The patients may not even complain or notice it, and some patients perceive it as blindness, and we must always look for it by confrontation or the Menas test, by which you just give a threat to the patient by your hand on one side, and on that side there will be no blinking, whereas on the other side, normal side, there will be blinking. And usually this is seen if the patient is having occipital lobe infarcts, but sometimes even without occipital lobe infarcts also you can see if the lesion is more proximal. As I said, pure cortical lesions do not usually cause dense deficits. They usually cause small deficits, the reason being that to cause a dense deficit, the patient has to have an infarct of the entire cortical strip, which usually does not happen unless the infarct is very big and involves subcortical regions also. So therefore, if a patient has a pure cortical deficit, you may just get one hand weakness or just facial weakness. Therefore, one can confuse them and miss them with the lower motor neuron palsy. If there's a cortical lesion, you may sometimes, it may present pure facial and you may think it's Bell's palsy. Or if a patient many times can come just with a wrist drop or a hand drop. So it's very important to do a complete examination. There may be some clues towards the cortical nature, like reflexes will be brisk on that side, plantar will be upgoing, like that. But it is important to know that cortical deficits can cause mini motor deficits rather than dense hemiplegias. Now, this is one example of a cortical deficit. This is a patient where you can see anterior cerebral artery infarct, and this patient had presented with a foot drop, right? Because that is what it will cause in the ACA territory. It will not cause a hemiplegia. And this is one patient, 80-year-old lady who was thrombolyzed also. She came just with hand weakness. In fact, she was doing puja in her home, and first time she noticed when she was doing puja, she could not approximate both hands. And that's how it was noticed. And scan showed that there was a cortical small infarct. So because it's a clinical discussion, that's why I'm trying to highlight and emphasize these points. As opposed to cortical lesions, pure cortical lesions, subcortical lesions cause dense deficits because this area is subcortical lesion. All the fibers from the cortex come down and then they are concentrated at the level of internal capsule and below. So therefore, even a small lesion here, which you can see, can cause a dense deficit, a hemiplegia or a hemisensory loss. So cortical lesions, focal deficits, subcortical lesions, dense deficits and involving more territory. And these are the classical examples of subcortical. It's called lacunar strokes. They can cause pure motor stroke. They can cause pure sensory strokes. They can cause sensory motor strokes. They can cause dysarthria, clumsy hand syndrome, ataxic hemiparesis. But important thing is that they should not have any accompanying aphasia, apraxia, neglect, or visual loss. And their CT scan will be normal, and or it may show an infarct either on CT or on MRI, which is less than 1.5 centimeter. This is because of the small penetrating artery occlusions. Occasionally, it can be little bigger than 1.5 centimeters if there's more than two arteries are involved, two penetrating arteries are involved. In clinical practice, many times we don't see pure cortical or pure subcortical. We see them, but many times we see a combination of them. Classical example being a cardioembolic stroke. Because once a cardioembolic stroke goes to top, it occludes the mouth of a major artery. So the major artery involves including the penetrating arteries, because penetrating arteries also arise from the major artery. So in a typical cortical subcortical infarct, as you can see here, the whole cortex is also involved, subcortical, the entire territory is involved. And this patient had an underlying atrial fibrillation. This happens usually because of big clots, which are cardioembolic. So therefore, it's important for us to know, am I dealing with a cortical infarct, subcortical infarct, or combined cortical and subcortical infarct, and then what is the location? So one location we already said it can be hemispherical, right-sided or left-sided. There we get help by the side of the plegia as well as aphasia. But hemisphere is not the only thing in the brain. Brainstem strokes also occur, and brainstem has its own geography. It can be in the midbrain, it can be in the pons, or it can be in the medulla. And if it's in the midbrain, This is one of the patients where you can see at the level of midbrain there is a small infarct, and all he presented was the inability to see up and some diplopia of a sudden nature. Similarly, Pons. Uh, so anyway, now, so what all I have said, I'm going to summarize it. In a conscious patient, because stroke patients can be conscious or they can be unconscious. In a conscious patient, as soon as we see a stroke patient and we have made a clinical diagnosis, historical diagnosis of stroke, first observation is to see whether the patient is preferring one side of the space, because that can be the first evidence that this patient is neglecting. If he is conscious, ask his name, time and place and a command to follow. This is very important. It gives us an idea about his speech functions. And as a bonus, we also come to know about his orientation and about the hemisphere. But that is very important. Third is, can he register a 5-digit number and repeat it backwards? But as a clinician, remember that you have to yourself also remember those 5 numbers. Sometimes we also forget. Actually, in the books, it's given 7 numbers have to be given. But I find it difficult to remember 7 numbers, unless it's my phone number, my own phone number. So 5 is also a good thing. There is a validation on 5 numbers also. And obviously, you cannot do it in an obtunded patient, but if a patient is conscious enough, you can give him so that you will get an idea about his recent memory, about his temporal lobe. Clearly, visual fields are very important, and in actual real world, it is not possible to test for homonymous hemianopia. That nasal fields are very difficult to test. If in an acute stroke patient, you do only the temporal field cut, you can corroborate from that. I have learned it first time in the US, where everybody used to do what they used to call field cut there. Before that, we used to always call it homonymous hemianopia and all. And when I went to States, I found everybody, oh, the right side field cut. And that was very useful. This field cut detection is very important. It's very easy also. It's just we have to know that we have to do it. So one of our postgraduates is sitting here, she knows. So it is important, because this is the first thing which will give you an idea, is it a subcortical or is it a cortical infarct? But sometimes they can happen in a big subcortical also. Can he recognize people and objects and letters? Can he draw a clock or any simple picture? Look for, after this, look for pupils, nystagmus, any gaze palsy, and we should not forget to look at the fundus. Look at any facial, palate, and tongue asymmetry. Look for focal weakness, and if none, look for the pronated drift. That means if the patient says that there's no weakness, then ask him to raise both the hands and see there will be drift on one side. That's how you can detect otherwise undetected focal weakness. And always we must check for reflex asymmetry and look for the upgoing plantar. Now this is a checklist, and each of one you cannot do in each particular patient. But if we practice it, I'm addressing mainly the students, if we practice it, it will not take you more than 5 to 7 minutes to do this quickly and come to a reasonably good conclusion what is going on. But many stroke patients are drowsy or they are unconscious. So there they will not cooperate for all these things. This is a checklist for them. Look at whether the patient has a gaze palsy or a neck deviation. That will tell you the localization of the lesion, where is the lesion. Press the sternum to elicit localization. The paralyzed side will not move. The non-paralyzed side, there will be movement. So you know he has got hemiparesis on the other side. Lateral rotated foot is very important. Look at his both feet. If one foot is laterally rotated, that may be the only evidence in the unconscious patient that there is probably a hemiparesis on this side. In unconscious patients also, we can do this visual threat. Bring the hand on his one side, it's called Minna's reflex, to elicit the field cut. And in an unconscious patient, nothing is more useful than a pupillary asymmetry. If the patient is unconscious, it obviously means either he has got a brainstem lesion or he is probably coning. So therefore, pupillary asymmetry is extremely important in an unconscious patient. It makes our life very easy. Like this is the example. You can see the asymmetry of the feet on one side, the lateral rotation of one foot. Okay. Well, this is usually stroke means weakness of one side of the body, but very rarely, sometimes stroke can come with an abnormal movement. So this is the MRI of a patient who had a hemichorea on one side, particularly in elderly people. Sudden chorea can be manifestation of a caudate infarct, as you can see in this patient. Now, when you gather all this data, based on that you localize the lesion and make a diagnosis. So on examination, this is the checklist. First of all, check. This is basically a summary of what I told you. Is the patient conscious or not? Look for cortical signs. Look for gaze preference, neglect, aphasia, attention, memory, visual cut, and any focal limb weakness. For subcortical, again, dense motor or sensory deficits, whether there's any ataxic hemiparesis, whether he has got dysarthria. For brainstem, we should not forget to look at pupils, extraocular movements, and in nystagmus. Ask him to take out his tongue, see whether the tongue is paralyzed on one side, how about the palatal movements, and if possible, check for cerebellar functions. Because a lot of times you make these are like notes of music. You just have to combine them and diagnosis will come out. If there's a aphasia in right hemiparesis, it's a left hemispherical stroke. If there's a swallowing difficulty, palatal asymmetry, pupillary asymmetry, and sensory disturbances, cross sensory disturbances, it's a lateral medullary syndrome. If there's a third nerve on one side and hemiparesis on the other side, it's a midbrain syndrome. But this data is important. Based on this data, we make a clinical diagnosis of stroke. So based on that, we make these 5 key stroke syndromes. Either a left hemispheric stroke syndrome, which will consist of aphasia, gaze, vision, with and without deficit, right hemispherical, which will be driven by neglect. Then brainstem, where you have got nystagmus, sometimes you have got internuclear ophthalmoplegia, and crossed motor or sensory deficits. That is one of the peculiarities of brainstem syndrome, that you get cross deficit, facial weakness on one side and motor paralysis on the other side. Sensory deficit on one side of face and on the other side of the body. If it's pure cerebellar stroke, you may get ataxia. On the other hand, if the patient is purely motor sensory, ataxic hemiparesis or dysarthria, clumsy hand, then we are probably dealing with a Lachner syndrome. Now, once we have made this diagnosis, because finally the job of a neurologist is not only to make the diagnosis, he has also to do something about that. And one of the main challenges is to first of all treat this patient, which will come in the subsequent talk. And second is to make sure to prevent this. And for preventing, we have to know why this happened, why this vessel occlusion happened. So therefore, for this you need a neuroimaging, you need an ECG to rule out atrial fibrillation or any other cardiac abnormality. You need a 2D echo. Sometimes you need a TEE, Doppler, if possible, MR angiogram, and in young patients, procoagulant workup. So even after we have made clinical diagnosis, every stroke patient must undergo these investigations to come to the cause or the mechanism of the stroke. So this will be my take-home message. Any acute neurodeficit, one should suspect stroke. Clinical diagnosis is important, but these days imaging is a must, because by that you will confirm your diagnosis and differentiate between hemorrhage and a ischemic stroke, because that's what is going to matter for the management. Classifying strokes determines the underlying subtype, and subtype is usually determined by clinical as well as investigations. And based on that, acute and chronic management is decided. Thank you very much. Any questions? Hi. Any questions or comments? I couldn't show you some videos because of some technical problem, but yeah, please, sir. Yes, we use it, and I'm going to talk about it in the thrombolysis lecture. We do. We carry it in our pocket all the time. Yeah, please. Well, as far as the question is very interesting, and once in a while we face it, which means that the patient is normal. As long as the patient has not recovered clinically completely, he has to be thrombolized. It's a stroke, right? So stroke is a clinical diagnosis. So if the patient has improved completely and MRI is normal, then it's a TIA. That is the proposed current definition of TIA. That patient should have recovered also, and MRI also should be normal. On the other hand, if your patient has not recovered, he still has a hemiplegia, but MRI is normal, diffusion is normal, still you will thrombolize him, because there are 1 or 2% of patients where diffusion may occur late, or it may be in the posterior circulation, it may not pick it up, or the quality. So you would. But if your patient has recovered, then you will not. So you have to go by clinical deficit. Is it all? Thank you.
Clinical examination, which at times is somewhat overlooked. One of the issues, of course, is stroke mimics. You can actually have a clinical picture that may suggest a ischemic stroke, but nonetheless it may actually have a different etiology. And that question comes in, should you actually what does it have implications in terms of whether you give thrombolysis or not. And I think the current feeling is that if it's a stroke mimic and you give them thrombolysis, the adverse consequences are minimal. So it is better to actually give them thrombolysis rather than withhold thrombolysis with the suspicion that it may actually be a stroke mimic. I think that in terms of some stroke syndrome that can be very difficult to diagnose as stroke syndromes. One of them actually is stroke syndrome like the Wernicke's aphasia. A lot of times these patients would only come in talking intelligible or what they call as the word salad because they don't really have any comprehension of what you're telling them. And yet the stroke often spares the motor cortex, so they would really have no focal deficit that can identify it as a stroke. And it's not uncommon for some of these patients to be in psychiatric wards. And then later on somebody does an imaging and finds out that somebody actually had an ischemic stroke. The other one that can be very notorious is patients who have posterior cerebral artery strokes and may actually involve not just the primary visual cortex but also the association visual cortex. So they may have a significant amount of neglect. And I actually remember one patient I saw many years ago who actually was a cab driver. And during the whole day, he actually had 4 accidents. And yet he never recognized that he was not seeing well on the right side. And perhaps he was always hitting the cars on the right side. But it does tell you that sometimes these stroke syndromes can be so difficult to make the diagnosis. And another one to be very cautious, which is very rare, is that you can actually have basilar artery occlusion, but really at the distal end of the basilar artery. And you may actually, in fact, spare the posterior cerebral arteries. And essentially what you may just have is an altered level of consciousness and perhaps some level of gaze problems, which if you don't look carefully, you will not notice it. And I think that the other thing is that, as you correctly mentioned in terms of diagnostic workup, I think the main thing that really can change the, in terms of treatment strategies is whether they have atrial fibrillation or not, because that would be an absolute indication to start warfarin. Every other ischemic stroke, pretty much the treatment today is antiplatelet treatment. And the other one would be if they actually have carotid stenosis or not, because that also makes a difference, because they would be candidates for both carotid endarterectomy or carotid stent placement. And I think that one last thing I want to make is more of an anecdotal story about the Babinski sign that we just saw one of the images for. And a lot of people don't recognize the whole sequence what led to the Babinski sign. And essentially both Babinski and Bocard were actually students of Charcot. And when Charcot passed away, it was either Babinski or Bocard who were going to be the next chairman. And then Bocard became the chairman, and the first thing he did, he fired Babinski. So Babinski had to go work in a small hospital. And yet in that hospital it described the Babinski sign. So it does tell you that regardless of what resources you have, you can always make an important contribution to science. So those are some of the things I wanted to mention. Thank you very much.
Thank you, Professor Kaur, for giving an excellent review of fundamentals of stroke. And next I would like to invite Dr. Suresh Giragani. Delegates to ask questions, keep it more interactive. This is a clinical review session, so yeah, you're most welcome.
Good morning, chairpersons and the audience. At the outset, I want to thank the organizing committee, Dr. Nabil and Dr. J.M. Kamuti for giving this opportunity. I'm going to talk about neuroimaging stroke, and I will be limiting myself to only hyperacute stroke rather than focusing, elaborating on other aspects like acute, subacute, and chronic kinds of stroke. And there is another talk tomorrow, I think, on interventional relevance of the imaging and its interpretation in relation to the endovascular intervention. So I left the probable risk management strategies or risk assessment strategies in imaging, those kind of stuff I left purposefully. So the objectives of this talk is predominantly to focus on hyperacute stroke and what are the imaging changes we see on hyperacute stroke, and what are the modalities we have. We have CT and MR. In CT we have parenchymal imaging, CT angio, and in the same MR we have MR parenchymal imaging and MR perfusion and MR angio. And once we discuss the modalities, we'll try to formulate and draw the protocols which we can follow in routine day-to-day practice. So the objective of imaging is basically to exclude mimics of stroke and hemorrhage, which contraindicate the administration of any intervention, whether IV thrombolysis or endovascular intervention. And we have to see what is the cause for the stroke, if it is there, and we have to establish the effect, that is, infarct is there, how much infarct is there, so that we can have a rough idea about the risk assessment. And in addition to that, we have the penumbra imaging to basically prognosticate the patient, and collateral imaging also for prognostication of the patient for various interventions. So the subcomponents of the stroke imaging include parenchymal imaging, vessel imaging, and collateral imaging is also part of the vessel imaging, and we have the penumbra imaging called the perfusion imaging. So coming to first the parenchymal imaging, it can be done by CT or MR. And in CT it can be done by non-contrast CT, and in MR the three basic sequences that we require for parenchymal imaging are diffusion weighted imaging, susceptibility weighted imaging called SWI, and FLAIR, the fluid attenuation inversion recovery sequence. So the basic paradigm of the goal of the parenchymal imaging is to assess the infarct core, how much it is, and to assess the age of the infarct, if it is an evolved stroke already, and probable subtype or cause of the stroke we have to establish. So the first objective, if you have a CT-based protocol and if you have a CT in hand, the patient is on CT table, the first observation you should do is to exclude the stroke mimics and hemorrhage. And hemorrhagic transformation of infarct, if it is there, and other stroke mimics, that is the first observation. If there is no hemorrhage, then you should go for any hypodensity. There are two types of hypodensities that we see in acute stroke or hyperacute stroke patients. One is the obvious hypodensity, the otherwise is subtle hypodensity. So if it is obvious hypodensity, if it is cortical based, wedge shaped and hypodense, and it is confined to the vascular territory, either MC or ACA, then it is truly an infarct. And in that case, you have to inform the clinician whether it is less than 1/3 or more than 1/3 of the MCA territory. We are talking in terms of anticirculation stroke. So that it can give an inference whether to go for IV thrombolysis or not by going with the conventional rule of more than 1/3 MCA territory, there is relative contraindication for IV thrombolysis. Then comes to the subtle hypodensity. You don't see an obvious hypodensity over there in the CT, and if you see a subtle hypodensity, how to recognize the subtle hypodensity? And there are some signs. Basically, you have to depend upon the symmetry of the brain in that case. Symmetry in the sense, if the stroke is on the left side, you have to depend upon the right side to compare. In the first image on the left, you can see that the insula is definitely hypodense as compared to the right side. The Gray-Wide differentiation, insula and the claustrum, the differentiation is gone on the left side as compared to the right side. And as well as the lentiform nucleus on the left side also, you can see more hypodense as compared to the right side. So this sign is called as obscuration of lentiform nucleus, and the right side image shows the insular ribbon sign or the hypodensity of the insula. So these are the subtle signs that you can delineate on NCCT in hyperacute stroke. The other signs, these are at the level of ganglia, that means at the level of basal ganglia. The other signs which include are at the level of Gray-Wide, the cortex, which includes loss of Gray-Wide differentiation. That is one of the earliest signs because of the ongoing formation of cytotoxic edema and vasogenic edema. And you can see as compared to the right side, definitely there is loss of Gray-Wide differentiation there. And you see more sulci on the right side at the same place in the parieto-temporal region. Whereas in the left side, you can see the effacement of sulci. And in the same case, on the left image also, you can see the obliteration of the sulci on the left side in the high frontoparietal region with loss of Gray-Wide differentiation. So it requires kind of little bit training, and you need to have a narrow window setting, narrow window and level settings to perceive these kind of changes, or the early ischemic changes, what we can call it as on CT. So to give an objective evaluation or objectivity to these early ischemic changes, aspect score was given, invented by the, actually designed with the Albert stroke program inventors, and it gives two scoring at two levels, and it pertains to the MCA territory only. And the inferior level is at the level of ganglia. That means you have to give scoring to the caudate nucleus, lentiform nucleus, internal capsule, insula. That is for the ganglia. And at the level of ganglia, you have to give scoring for the the MCA territory also in the frontal operculum and in the temporal operculum in the form of M1, M2 and M3. And once you go on the right side image, once you go to the more superior level where the ganglia end, you will give 3 more points, M4, M5, M6, anterior to posteriorly. So there are total 10 points. So the interpretation is the more hypodensities are involved in this particular area, that much amount of number will be subtracted from the total number. So that means it comes to if 2 areas are involving, the aspect score is 10 minus 2, that is 8. If 3 areas are involved, aspect score is 10 minus 3, that is 7. So to have a realistic view on the CT image, so we have to compare on the right side the normal the anatomy, the yellow one showing the caudate marking, the red one showing the insula marking, the blue one showing the lentiform and the internal capsule markings. And apart from that, there are 4 points for these sections, and apart from that, we have the MCA territory, 1, 2, 3, respectively anterior to posterior. Supraganglionically also, you have the M4, M5, M6, and the total score is 10. And it should be, the counting should be done in all the levels, all the cuts, and the cut should be preferentially 5 mm thick. You should not interpret these images and the thin section images which are acquired on the CT scanner, but if you recon them to 5 mm thick sections and assess the every level from the ganglia to supraganglionic level, then the interpretation will be correct. But it has its own limitation, as I said, that it is only for MCA territory. Although aspects have been applied for posterior circulation as well as the rest of the territories, it is not routinely in the clinical practice, and it is not useful for watershed infarcts. And if you have an already existing chronic changes or ischemic changes or microangiopathic changes, it is very difficult to differentiate sometimes from the hyperacute, the early ischemic changes. And if the patient has moved during the study or the motion artifacts are there, definitely it's going to alter our scoring. As I said, CT has limitations in the lacunar strokes as well as watershed strokes, and even in posterior circulation also CT has got limitation in view of beam hardening artifacts in the posterior fossa. So this is one of the example, the lacunar stroke in the thalamus, not at all shown by the CT. And the next imaging modality that is in parenchymal imaging is MRI. We do DWI, SWI, or GRE sequence and flare. DWI is basically based on motion sensitive gradient sequence, gradient pulses, so that you can see the diffusion of the water molecules at the cellular level. So whenever there is an infarct, ongoing ischemic process, there will be impairment of the membrane channels. So the water inflow and outflow will be impaired, and within the cells there will be restriction of the water movement. That restriction will cause brightness on the diffusion weighted image and darkness on the ADC image. And this was one of the case of hyperacute infarct. You see the flare image, absolutely normal. Maybe you can see subtle gravid differentiation loss, but the diffusion shows the massive ongoing ischemic process in the form of DW brightness involving the left MCA territory. And in the same image, you can see on the third image, the sulcal hyperintensities are there, suggesting that there is slow flow in the distal vessels in the MCA. So this particular imaging is also useful. The diffusion flare combination is also useful in case of awake strokes that I will elaborate later. And in established acute infarcts, the usual diffusion volume corresponds to the flare, and the ADC will be still dark. And the ADC values usually will become normalized or pseudo-normalized within 1 to 4 weeks. And in subacute infarct, you have contrast enhancement that is typical of gyriform pattern. And in this case, you can see a lesion mimicking a Mars lesion in the left superior frontal gyrus, and it is showing a gyriform pattern of enhancement. It was initially interpreted as a Mars lesion, but going by the typical pattern of gyriform enhancement, it was diagnosed subject to infarct. Chronic infarct shows increased ADC and no restriction, as you can see in this case in the left centrum semiovale. This is due to T2 shine through artifact. Apart from the infarct core and aging of the infarct, we can assess the stroke subtype also. If you have a large territory of involvement, the particular territory of involvement, simultaneously having vessel occlusion, as in this case in the right MCA territory, with diffusion restriction in the frontoparietal region with M1 occlusion, you can categorize it as large vessel stroke. If there is no major vessel occlusion with involvement of the perforated territory, you can call it as small vessel stroke. And if they are scattered, not restricted to any particular territory and multiple territories of involvement, you can call it as embolic stroke. And watershed strokes, typically due to hypotension or proximal critical stenosis, will involve the watershed territory of the deep white matter or at the junctional zones of ACMC or MCAPC, and you have usually you will find critical stenosis involving the carotids. And subarachnoid hemorrhage patients with vasospasm will also have similar kind of the watershed territory of involvement. And diffusion is not always sensitive for strokes, and especially in posterior circulation strokes, probably because of the thick sections we get, it can be negative. In this case of a proximal basilar stenosis with TIA corresponding to patient presented with paraplegia, and you have the diffusion negative, and it was repeated on the next day, and you see a diffusion right lesion in the pontomedullary junction. So it can be negative, especially in the first 12 hours, especially in posterior circulation strokes, up to in 10 to 15% of cases. So diffusion, if you can summarize, it is the most sensitive imaging technique for assessing the infarct core, how much infarct already established. And DWA flare is used as a marker for strokes with unknown onsets to evaluate the penumbra. And diffusion is a component of MR-based perfusion. Next, coming to the parenchymal part of imaging of MRI, SWR, GRE, we do. It is basically whenever there is an hemorrhage, there will be blooming on the SWI. And there is one more concept that has come up recently, that is the prominence of cortical veins. Prominence of cortical veins in case of ischemic stroke in the ipsilateral side. You see the left MCA occlusion is there in the third image, and in the left cerebral hemisphere there is more prominence, more darker cortical veins as compared to the right side. This was explained by the hypothesis in which there will be misery perfusion and increased oxygen extraction, because of which there will be more deoxyhemoglobin to oxyhemoglobin ratio, leading to more darker cortical veins. So this was also used to give a kind of mismatch imaging or the penumbra imaging between the DWA and SWA. As you see in this case, there is infarct involving the insula as well as caudate head and centrum semiovale. But the prominence of cortical veins is extending above the supraganglionic level into the frontoparietal region, suggesting that there is significant penumbra in this particular case. So SW is useful basically to exclude hemorrhages, that is a basic point. Apart from that, you can have the extent of thrombus that is detectable by SWA called the susceptible vessel sign, that I will show you later. And we have the new concept called DWA-SWA mismatch also, that is useful for penumbra imaging. So to conclude the parenchymal imaging, the infarct core, which is the important one for parenchymal imaging, is assessed by NCCT aspects as well as the DWA. And hemorrhages can be excluded by in CT by plain CT only, whereas in MR it is excluded by SWA or GRE. And stroke subtype can be evaluated by DWA and NCCT. Coming to the second part of imaging, that is vascular imaging. The purpose of vascular imaging is to have whether the occlusion is at the level of proximal or the distal occlusion, it is singular or multiple, and probable pathology should also be delineated like atherosclerotic or embolic or dissection or vasculitis. We have various imaging modalities. Coming from even NCCT SW can show some vessels which have lodging the thrombus, and the main imaging modalities which are employed routinely in CT imaging, the stroke imaging protocols are CT angio or MR angio. In MR angio, you have both TOF, that is non-contrast time of flight imaging, and contrast enhanced MR angio also. And DSA, anyway, if you are going for intervention, it can assess the angiographic images. The first, the non-vascular, non-contrast CT, the non-contrast CT can show some amount of thrombus information, that is called the hyperdense MCA sign or hyperdense basilar artery sign. So it can show the extent and the length of the thrombus sitting over there in the MCA. It has low sensitivity, this particular signs, but has very high specificity. It can be seen bilaterally sometimes maybe due to calcification or high hemochromatomic levels. So these should be kept in mind before interpretation. Similarly, GRE also, this case you see a very poor imaging because of motion artifacts, and you don't see any IC on the right side, but the exact level of the extent of the thrombus is shown on the GRE images. You can see the blooming of the right M1 segment as compared to the left side. And you see the ongoing infarct in the right MCA territory in the diffusion weighted imaging on the right side. So simultaneously you can have, you should image the neck vessels and arch also to see any proximal occlusions, especially proximal stenosis, which is very important for endovascular intervention. And this is a case of evolved left MCA stroke, which on further evaluation found the patient found to have left ICA critical stenosis. And the other pathology that can present as dissections is the dissection. This is a case of aortic dissection extending into the right common carotid artery. And the dissected false lumen shows thrombus in it, and this was a young patient presented with chest pain, retrosternal chest pain and seizures, and on evaluation found to have right MCA territory infarct with aortic dissection. And this was one of the interesting cases. We have the here we had left MCA territory infarct. We did the MR angio and we could find anything. Large vessels were okay, and the CT angio was done, including the neck vessels and intracranial vessels. And the left CC showed definitive hypodensity in its anterior wall, anterior medial wall. And to confirm the nature of this hypodensity, we did the carotid duplex and we see the floating thrombus. And probably this floating thrombus is showing the throwing the emboli distally into the left MCA territory. So it is very important that whenever you do stroke imaging in the first go, you should include neck vessels. Apart from we routinely try to do only intracranial vessel imaging, but it's very important to have arch vessels as well as the neck vessels to be included in the study. And this is one of the classical present angiographic pictures. The lateral medullary syndrome or pica territory infarcts, we should always suspect dissections in the vertebral artery territory. And so you do the angiogram or the MRI, you will see flap kind of picture. I don't have a pointer here, but in second image as well in the videogram. So video angiogram, we can show the flap in the vertebral segment. You can see two lumens with differential contrast densities. To compare among the modalities, MR angio overestimates the tau of MR angio overestimates the extent of stenosis. Sometimes it shows slow fly as complete occlusion. So it has got oversensitivity in detecting the slow flows as well as critical stenosis. So this was one example. The left side image showing the MR angio showing almost near complete occlusion of the left ICA. You do CT angio, it's almost only 50 to 60% only. So to conclude the vascular imaging, we should show whether it is stenosis or occlusion, complete occlusion, and the location we have to see, and probable length of thrombus. If you do collateral imaging, you will get to know that, and extent of collaterals. So among the various imaging modalities, the CT angio, non-contrast TAF MR, contrast MR angio, and DSA, the susceptibility to motion artifact is very less, and it is in CT angio, and CT angio is very fast, and spatial resolution is also high as compared to MR angio, and it is fast and less susceptible to artifacts. And whereas MR angio, in TAF MR angio, there is no need for contrast. That is one of the advantages. So if you want to go for vascular imaging, dedicated vascular imaging, CT definitely scores over the rest of imaging modalities. The recent concept that has come up in the positive endovascular trials is collateral imaging. This is basically a vascular corroborative of ischemic penumbra. The more collaterals we have at the time of initial onset, there is more good prognosis if you do intervention. So it gives an eligibility criteria on imaging. So collateral imaging is not done in a single phase CT, but it has to be done in a multi-phase CT. Multi-phase CT means you acquire the volume in multiple phases immediately. So early arterial phase in the phase 1, concentrating from the arch vessels to the vertex. In the second and third phases, we do only concentrate on the skull base to the vertex. So totally, we acquire total 3 phases. So this was one of the case examples of left M1, M2, the MCA bifurcation occlusion. You can see that in the first image, there is poor antigrade flow into the M2, M3 branches, whereas in the second phase 2 and phase 3, you can see collateral formation, suggesting that it's a good candidate for recanalization. There is grading also for good collateral, poor and moderate collaterals, depending upon the extent of phase delay. Coming to the third component called the penumbra imaging, this is a well-known concept that basically infarct is a dynamic process. You have the central core surrounded by penumbra because of collateralization, and if you neglect that, it is going to evolve further into infarct core. So the basic purpose of all the interventions as well as the imaging is to detect how much infarct core already established and how much salvageable penumbra that is left. The basic concepts going into penumbra, that penumbra has the in-between blood flow rates in between the allogeneic tissue and infarct, but it's still salvageable if you can recanalize the artery that is involved. So if you can select the patient properly by using penumbra imaging, you can prevent hemorrhagic transformation and promote recovery. It is very helpful in patients who are coming outside the window period of 6 hours or 8 hours, and in post-circulation strokes and wake-up strokes, and in patients who are in like situations in which there is clinical indecisiveness is there regarding the interventions. So perfusion can be done, the penumbra imaging can be done by CT perfusion, MR perfusion. So the concept is the flow is equal to volume per time, and whenever there is arterial occlusion or arteriostenosis, there will be slowing of flow leading to autoregulation. That autoregulation gives rise to the vasodilatation of the arterial territory, and once there is vasodilatation, initially the blood volume, the amount of volume that is there reaching the tissue will be normal, and the flow will be decreased. The time taken to the blood to reach the tissue perfused will be increased. But if it keeps on decreasing, if the flow keeps on decreasing further, what will happen is the the blood flow will be decreased and the volume will also get decreased. So you have in the penumbra the three typical combination of parameters, that is increase in mean transit time and decrease in cerebral blood flow and absolute decrease in cerebral blood volume. So this is called the penumbra, and we get two sets of imaging, one for the cerebral blood flow and one for the cerebral blood volume, and if you subtract the flow minus volume, it gives rise to penumbra. So I'll show a case example how we do and we interpret CT perfusion images. So this is the NCCT image, and patient presented with aphasia, and you have subtle gravar differentiation lost in the left temporoparietal region. And so what we do is we give 50 ml of contrast after a 5-second delay and or 50 seconds, and try to acquire the images at the same level like this repeatedly. So it is available and can be done only on faster scanners only. From 16 slice onwards we can do 16 slice, 32 slice, 60 to 64 slice we can do. So this is the level of basic angle. You see what is not demarcated on the initial images can be demarcated as hypoperfused tissue in the left, the periatrial region and the cortex involved in the posterior division of the left MCA. And there are algorithms that will calculate the perfusion parameters there. And what you will get is the color parameters in terms of volume, mean transit time and cerebral blood flow. So the color coding will be there. The blue will indicate the less value and red will indicate the higher value. The first image in the upper left, you can see that blood volume is reduced in the corresponding area, and in the mean transit time as well as the flow images, you can see more amount of decreased value is there for the cerebral blood flow and more value is there, more increased value is there in mean transit time. So if you can subtract the volume of the CBF minus CBV will give rise to the penumbra. So in the lower left image you can see the penumbra. The infarct core is the red one, whereas the blue one is the penumbra. So you have definitive volume of penumbra as compared to infarct core in this clinical situation. Another case I'll show you on the MR. So it has Initially when it came up, it was very interesting and there were trials having positive intention for treating the patients using CTP. But the most important problem that has come up with CTP till now is standardization of parameters. How much CVV you have to encode for infarct to define infarct, and the thresholds for the penumbra also are very limited. So it's always a limitation, and it may vary between the single vendor and between vendor to vendor also. So that's always a limitation. And MR perfusion, similarly, we can do another case of MR, perfusion done using an MR. 45 female, left hemipasses within the window period, SW normal, T2 apparently normal, diffusion evolving stroke in the MCA tertiary, ADC dark, and MCA occlusion is there. And you do perfusion imaging, you will get 3 maps. One is the MTT and mean transit time, blood flow and blood volume, all the 3 you will get. So what we do is we compare the mean transit time, the maps or the CBF maps with the diffusion maps, and we'll subtract the value one from each other, and we will evaluate the mismatch, area of the mismatch. So the various trials have incorporated either CTR, MR based protocols, and the parameters that they have taken is 20% more than the infarct core as a criteria to include the patient into the endovascular trial or IV thrombolysis trial. And they have taken various parameters, like for perfusion, they have some people have taken Tmax or MTT. So the basic, the paradigm for the basic issue of difference was the setting of the standards. The recent successful endovascular trial, the SWIFT trial as well as the Extend 1 IA, both have included CT perfusion and MR perfusion. And as of now, there is no level 1 evidence for stroke, the CT perfusion in stroke imaging. But it definitely improves the infarct core evaluation in CT, the penumbra imaging as well as the routine CT based protocols. And as I said, it is very useful for patients evaluating outside the window period and wake up strokes. So we have discussed about the imaging modalities, how we are going to interpret them. But in a routine day-to-day practice, what kind of protocols we are going to implement at our institution. So that is always a subject of debate, and it's been debated for a while. So what is a good imaging protocol? Just we have to retrospectively see what are the positive and negative trials that have undergone as far as endovascular trials are concerned. So all the failed trials, many of the failed trials, they didn't have proper imaging evaluation with respect to large artery occlusion is there or not, and evaluation of the infarct core and perfusion. Those things were not evaluated in many of the failed endovascular trials. Whereas in the successful clinical trials, we have proper evaluation by either CT angio or MR angio, and infarct core evaluation by either by aspects or CT perfusion or MR based perfusion methodologies. So a good protocol, whenever you want to implement, so it should have accurate estimation of infarct core and the level and extent of thrombus, and reasonable approximation of the penumbra should have. And at the same time, the most important is that you should have, you should avoid unnecessary time delay. You can see that the onset to puncture time in the successful trials is between 180 to 260 minutes. That is 3 to almost 5 hours. So the basic thing is that whenever you are doing imaging, you should not waste much time into going into the intricacies of the things, rather than provide triage kind of stuff. So we have CT-based perfusion, CT-based protocols and MR-based protocols. In CT-based protocols, we can do NCCT, single-phase CT or multi-phase CT or CT perfusion. And in MR-based protocol, we have to do MRA, MR angio, plus or minus MRP. So which is the best out of CT-based protocol and MR-based protocols? So out of the 5, the positive trials which have come up, most of them used CTA and few of them used MR-based protocol. And collateral imaging was done in 1 of the trials, and perfusion was used in 2 of the trials. So to debate whether CT is good or MR is good, that it comes down to 4 or 5 points, whether CT or MR is good. Basically, time efficiency, availability is very good in respect to CT-based protocols. And for vascular imaging, definitely CT scores over MR. And the MR scores over CT in estimation of ischemic core, and CT. So you can go for CT or MR based protocol, but you have to mind that you should not waste much of the time while evaluating the patient for imaging. And if you want to go for CT based protocol, you can do NCCT, CT angio from neck and intracranial vessels, and CTP. As of now, there is no evidence, class 1 evidence for level 1 evidence for CTP. And if you want to go for MR based protocol, you have to do SWA, DWA, flare, and MR angio, neck and intracranial vessels, plus or minus MR perfusion. So the centers, the West centers, which are doing very high volumes, two centers, one is the Mass General Hospital and the other one is Calgary Stroke Group. The Mass General Hospital is doing what they are doing is they are doing CT based protocol, NCCT followed by CT angio, and at the same time they are adding a diffusion weighted imaging to have an idea about the infarct core. So that is their protocol. They usually, unless until it is for a trial, they avoid CTP. And the Calgary group, they go purely by the CT based protocol. They do NCCT, do aspects for NCCT. Even for lacunar strokes and post-circulation strokes, they do NCCT. And they do CT angio, that is multi-phase, plus or minus CT perfusion. And for post-circulation, there are no definitive guidelines as regards to endovascular intervention as for imaging. And you can go for MR based protocols because it has more sensitivity to detect strokes in post-circulation as compared to CT. And for evolved stroke, you can have a simple parenchymal imaging followed by angiogram, including the neck and intracranial vessels. To conclude, that stroke imaging is basically time-based. The patient comes in within a window period of 6 hours, the imaging going to be different, and it's going to be different if it comes after 6 hours. So it's basically a dynamic and time-based imaging protocol. And the basic three important points that we have to evaluate, we have to conclude once we do imaging and inform the clinician are infarct core and extent of thrombus, level of thrombus, and the penumbra. Any probable salvageable tissue is there or not. And it should be very simple, timely in execution, and it should have objectivity, and it should not have much of intra-observer variability. Thank you.
As you rightly said that the ADC changes on the MRI disappear before the diffusion. That means if you do a scan after 2 weeks, diffusion may still be there, but ADC may not be there. That is as far as they disappear. What about the appearance? Suppose if we take at 5 minutes or 10 minutes after the stroke, do they come at the same time? Because rarely we have seen diffusion coming, but ADC not showing up. Is there any data on that?
ADC will come first, sir.
ADC should come first. So that means that if there is no ADC, then it is definitely a shine through
I think so.
in the acute stroke?
In pediatric stroke also, in HIE and all, we evaluate by ADC rather than diffusion weighted imaging. There are aspect score even applied to CT is also there, and I was attending one of the conference which was done being conducted by the Calgary group. They asked the same question. They said like they do CT for post circulation also. So it's more about your eyes being trained to the CT rather than anything else. So we are used to MR based diffusion so that we can easily catch up the infarct core. But if your eyes are used to the Gravert differentiation loss, detection of the Gravert loss in CT, and then probably people are going for CT-based protocols also in post-circulation stroke. But definitely there will be beam hardening artifacts, as I said, especially for the brainstem and picotoroidal lesions. Sometimes you will end up over-diagnosing the things. It's better because we have to have interactive kind of window settings rather than fixed windows. We can't read them on the film probably.
Comprehensive presentation. I just would like to add something to the protocol. What's about the neuroimaging protocol in resources limited situation? So not all the stroke units have availability of MRI and MRI perfusion or CT perfusion. In addition, what's about the neuroimaging and clinical mismatch? If you think about the MRI diffusion and you look to the infarct core and you look to the NIH stroke scale and you find a clinical mismatch between the MRI and the clinical presentation of the patient. So I would like to add the protocol in the resources limited situation.
And the question is about the protocol in resource limited situation, right, sir?
Yes.
Yeah. Again I should quote the Western practice only. They have two kinds of referral the centers. One is a primary stroke center and the other one is a comprehensive stroke center. All the primary stroke center will have a NCCT, and they can decide upon whether they can give IV thrombolysis or not based upon the clinical examination and exclusion of the hemorrhage on CT. Once you do the CT and exclude the hemorrhage, and if you are confirmed that it's not a stroke mimic, and you give the thrombolytic and shift the patient to comprehensive stroke center immediately. And in our city, maybe all the corporates having the software and the stuff that is required for CT angio at least. So maybe that is a more practical thing. You do a CT at the periphery and decide for IV thrombolysis, start the IV thrombolysis and shift to comprehensive stroke center and give, you do proper vascular imaging and if required go for endovascular intervention.
One comment about it is whether it's a CT protocol or MRI protocol depends upon the center where it is available and the expertise one develops in each one of the modalities. Number one. Number two, one should be very conscious about the age and the comorbidity of the patient when you select a CT protocol because of the contrast induced nephropathy are significantly high in a significant proportion of patients who are aged, who have got diabetes and other things. Therefore, MRI protocol is much safer as you pointed out. Second thing I think he stole some of the word which I want to say is that with regarding to large number of centers having CT which is easily available in most of the centers, I think the CT pickup sensitivity should be increased by appropriately designing the algorithms which can pick up, as you said, the aspect score, or the window and level setting need to be put in a proper way. The direction should be given to pick up the early changes in the strokes.
As you rightly said, it requires more training, and maybe the guy who is sitting in the comprehensive stroke center can go to places and train the physicians over there as regards to the aspect score. That is, as you rightly pointed out, sir. And regarding the first thing, there is a paper in AJNR regarding the outcomes, as requiring the outcomes for doing CT angio with or without serum creatinine evaluation. And they have a study group and the control group, and they have concluded that there is no difference even if you do the CT angio imaging without the evaluation of serum creatinine. So they have come up with a code called neurons over nephrons. It's always neurons over nephrons. You can save much amount of time by not doing serum creatinine. So in their study, what they quoted is almost none of the patients require dialysis at the end of the stay in the hospital. There may be rise in creatinine, but none of them required dialysis to treat them.
Thank you for all the talks, clinical and imaging. That's the basic. We at the periphery, we still go by the CT clinical mismatch, especially for the initial management of an acute stroke. We see the NIH score and CT scan with the settings to make it darker and try to see the infarct size. Go for thrombolysis, and then within 1 hour we go for the MR angio, or we start the lysis and then get the MR angio to see the vessels, to bridge it if required.
Yes.
Where there is no CT perfusion, we still find the bedside CT imaging mismatch good enough for the initial most of the patients.
This is definitely a big concern. Currently, primary stroke center and comprehensive stroke center, that model is definitely going to flourish. But big concern for primary stroke center or spoke hospitals, so to speak, big concern from financial standpoint is patient loss. So they do not want to transfer every single patient to a comprehensive stroke center where there would be perfusion imaging and further interventions. So there are some trials going on currently where they are trying to see some cortical signs that would suggest it's a large vessel. Let's say somebody has aphasia and weakness, we know for sure that it should be a large vessel. Like clinical probability is very, very high. So that patient is good for transfer. However, if somebody is just pure motor, their NIH stroke scale will be quite high, but may not have any cortical signs. And it may be a small lacune. So transferring that patient to comprehensive stroke center, doing all the perfusion, wasting resources, and finally saying it's a lacune. So those trials are actually ongoing currently. They are making some EMS protocols, so we can further study this, and hopefully that will help answer that question.
Couple of comments. It was an excellent presentation. I think one thing I would actually mention is that an additional thing, you can look at the plain CT scan in an acute ischemic stroke patient is the presence of gaze deviation. And Dr. Heriel did some work on it and he mentioned it, and I didn't pay much attention to it. I should have. And then subsequently one of the radiology residents who was working with us looked at 1,200 ischemic stroke patients and looked at the presence of gaze deviation on the CT scan and found that you can see it around 40% of the patients. But more importantly, if you see gaze deviation on the CT scan, the rate of death and disability is like 40% higher if you can pick that sign up. Whether that actually can replace clinical gaze deviation assessment or not, I do not know. But it's something that's very simple to get and may actually have prognostic value. The other thing I wanted to mention was about collateral formation. And when we started doing angiograms for acute ischemic stroke, we would see patients with middle cerebral artery occlusion, and you would see collateral formation through the anterior cerebral artery going through the cortical or PL collaterals and filling part of the middle cerebral artery distribution. And I used to teach people that this means that there must be chronic process. So maybe these patients had high-grade stenosis to start with, and that's why the collateral formation has occurred. So it was more of a chronic process, not an acute process. And then one day, we were doing an angiogram, and unfortunately during the angiogram, there was an emboli, and it occluded the middle cerebral artery. And what we saw on the angiogram was instant development of collaterals after the occlusion. So right on the table, the stroke happened, and then you can actually see an instant development of collaterals. So that made us think that maybe these are pre-existing channels, and it's just an activation of pre-existing channels. This is not like a new vascular formation. And then subsequent to that, every time we would do an angioplasty of the middle cerebral artery, when the balloon was inflated, so you actually have an artificial occlusion of the middle cerebral artery, we would actually inject some contrast, and you can see instant collateral formation from the anterior cerebral artery into the middle cerebral artery distribution. And there is variation in the extent of collateral formation, but nonetheless, it's instantaneous. And then subsequent to that, we also started looking at collateral formation in the posterior circulation. And you can actually see collateral formation on the cerebellar surfaces. So branches of the posterior and inferior cerebellar artery were anastomosed with this anterior inferior cerebellar artery on the cerebellar surfaces. So there is actually robust collateral formation that can even happen in the posterior circulation. So I think that this whole concept of collateral formation keeps evolving. And now we are actually dealing with a new concept, which is that the collateral formation over a period of acute ischemia may start to degrade. So the collateral formation that you see at 1 hour, at 4 hours or 6 hours may not be as effective, because some of these channels are small vessel channels that are getting plugged up with leukocytes and platelets, and actually you're starting to lose this collateral formation.
Thank you, sir.
Thrombolysis in ischemic stroke.
Full now. Stroke, whole of world has a long tradition of stroke, and those of you who have come first time, I think Dr. Qureshi has probably come first time to Hyderabad, I would request you to take a tour of the old city of Hyderabad, which is a spectacle, one of the oldest cities in the world. And there's a Unani hospital there, which I'm showing you here, near Charminar. And they also have been treating strokes. I mean, strokes are not happening only in the last 20 years. And one of the very popular method of treating strokes in Hyderabad is by applying pigeon's blood on the paralyzed arm. They call it kabutar ka khoon. And even a lot of people have faith in that. Even those patients which we have thrombolized also get a little bit of kabutar ka khoon on their arm to think it may work, because IVTPA still has some deficiencies and it doesn't guarantee you cure. But what I'll be talking today is guidelines and cutting edge practices. The original topic was guidelines and more. And I was thinking, what is this more? So I think that is probably going beyond the guidelines. So the questions when we think of thrombolysis is, as we have already emphasized, is it a stroke or a stroke mimic? Is it ischemic or is it a hemorrhagic stroke? Does the stroke qualify for thrombolysis? How to thrombolize, how much to thrombolize, and how to observe, and what if the complications occur? So suspect stroke, as we said, in a sudden focal deficit, which can be hemiplegia, monoplegia, visual. Okay, I always forget that. Okay, yeah. So any sudden neurological deficit can be a stroke. And in the background of the risk factors. Rarely you may not have risk factors. In about 20% you may not have risk factors, but suspicion is the most important thing. Or is it a mimic? Focal seizures with post-ictal palsy can deceive anybody. Hypoglycemia causes focal seizures. Therefore, now it is said that the only blood test you need before giving thrombolysis is blood sugar. In fact, if Padma would have been here, she would have told you that this platelet count and PT and INR, it's not important at all, because she in her study did all that, and now it's not required even by guidelines also. But the only blood test which is required is blood sugar, because hypoglycemia can just mimic a stroke. Drug poisonings, particularly sedatives and all, can just look like posterior circulation stroke with that nystagmus and ataxia. Hyponatremia, migraine, and functional. We have to make sure, particularly if the patient is a doctor and the stroke is functional, then the plantar also can be upgoing and the reflexes also can be brisk on one side. I have seen one such patient. And so it is very important. And as Dr. Adnan Qureshi has said very rightly, that sometimes it is difficult to differentiate, and when you are in doubt, just do it. Don't worry about it. Even if it's a mimic, just thrombolize it. The chances of complication will not be more than what it would have been in a normal patient. So if it is a stroke, then for IV thrombolysis, this is the key question. And we have to really focus on this. History from the patient and eyewitness. Was the event sudden? Sometimes patients are lay people. They are not able to pinpoint exactly, was it at 11, 10 or nobody looks at watch when the deficit occurs. So you have to corroborate the evidence. What was he doing at that time? Was he seeing a TV serial at that time? Which TV serial he was seeing at that time? Okay, he was seeing this serial which comes between 9 and 10. So all that effort is very important. And obviously, what was the event? Peripheral pulses, auscultation of heart and fundus is very important, because you will save yourself from committing some mistakes. Sometimes CVT and all those things can come with an acute deficit, so it's important. Neurological evaluation, when you are thinking of a TPA, has to be quick and focused, because time is brain. Every second, every minute counts. It does not have to be a neurologist's examination, which is very over-intellectual. It doesn't matter at that time whether it's in upper pons or middle pons or lower pons. What's important at that time is that, is it a stroke? So therefore, all that what I see, spend less time on it and spend more time on this NIH's stroke scale, which was asked in the first question. Now, NIH's stroke scale, basically, because this is a heterogeneous audience, we have some people here who are leaders in the stroke, but there are some people who are uninitiated, they are students. So for them, I'm saying that this is a stroke scale which basically measures the burden of stroke in one particular person. It measures the neurological deficit. And it is like, it gives marks, it gives points for each neurological deficit. Like, for example, this is level of consciousness. If you are normal and alert, you get 0. But if you are comatose, you get 3. If you are drowsy, you get 1. So for every deficit, there are marks. Like, for instance, take gaze. If it's normal, you get 0. If it's partial gaze, you get 1. And if it's forced deviation, you get 2. If it's visual field, if you are normal, you get 0. So for each deficit, if you are normal, you get nothing. And as you keep on accumulating deficits, your score keeps on increasing. Golf game is like that. In golf also it's like that. As you lose, you accumulate points. So NIH is like a golf scoring. And the total scale is 0 to 42. of us in this hall at this time have hopefully zero. That means we are normal, we have no neurological deficit. But if we have all the conceivable neurological deficits in the world, then the score will be 42. I haven't seen personally any patient with 42 scores so now, but 30, 35 all can happen. But it is important, and all residents should carry this in their pocket all the time, even after 15 years or 20 years of TPA also. We can't remember. So we must check it, score the patient, and measure it at where does he fall in this scoring system. NIHS, and we have to get actually certified, particularly if we are doing research. Even without research also, it's easy to get certified by web-based methods, and you get the NIHS certification. Nurses also should get. So based on this, stroke has been arbitrarily graded. If your score is less than 4, we say it's a mild stroke. If it is 5 to 20, we say it's a moderate stroke. And if it is more than 20, we say it's a severe stroke. This is in general. NIH has its own limitations and all, but that's a different topic. But in general, mild, moderate, and severe. But other thing which we must quickly do when we are assessing a patient where we are considering TPA, that clinically we should think, is it a large artery stroke or is it a small artery stroke, which you said very nicely. Because if it is a lacunar stroke or a small artery stroke, that means if this is the one involved, then this patient may not need endovascular management and he can be managed conservatively in any center, even in a remote area. That means if he has one of those 5 syndromes, like pure motor, pure sensory, without cortical deficit. But on the other hand, if the patient is a little drowsy and he has got gaze deviation on one side and is aphasic and all, then most likely this patient is having a large artery disease, which means that the clot is somewhere here and it's not dislodged. And these patients do not respond very well to IV TPA. You may have to think of intervention, endovascular intervention in these patients. So that judgment we should make while we are examining the patient only, that am I dealing with a small artery or large artery, and to a reasonable degree, we can make that diagnosis. So we should have an NIHS stroke scale, and we should also have that, am I dealing with a lacunar stroke or is it a large artery stroke? Now, when we suspect a stroke at that point in time, that can be a general physician, that can be a neurologist, that can be anybody, we should not lower the blood pressure unless it is 220 by 120 or unless we are considering thrombolysis. But even if we are considering thrombolysis, we should not lower it more than 180 by 110, right? But there you can lower. And that also there are specific drugs for it. We should not use sublingual nifedipine, which is done in periphery, because it causes a precipitous fall in the BP and the patient will worsen. So there are very specific drugs like labetalol or enalaprolate. Labetalol is easily available, by which you can reduce it to some extent. We should not use intravenous dextrose reflexly as we see a stroke patient, because it is bad for the neurons. It causes lactate and increases the damaged area. We should not give heparin. Ideally, we should not give aspirin also if we are planning thrombolysis, but some people may give. And we should not fall into this TIA trap. You know, after TPA came for first 10 years, and rarely now also, we have to argue with non-believers who say that, what if it's a TIA? What if it improves? So we should not fall in that trap. As long as a patient has a deficit, even if it's a partial deficit, it's not a TIA. TIA is always something which happened. It's a retrospective diagnosis. So whether it will improve in next 1 hour, whether it may improve, we should not get into those philosophical questions, because it may improve, but it may not improve also. So we cannot wait for 3 hours. So TIA, we should not even think. And in all stroke patients, we must have a checklist, consider thrombolysis, either treat him ourselves or refer him urgently. One of the debates which is happening in stroke circles all over the world, including India, is that should it only be neurologists who should treat stroke, or can general physicians also treat stroke like they treat myocardial infarction, they thrombolyze myocardial infarction. So by and large, there seems to be an opinion now that if a general physician is trained, if he understands stroke, and particularly if he takes advice from neurologists, they also can, because it is such a common disease that it's not practical for a neurologist to go each and every remote area. But they should know what they are dealing. So therefore, it's important for everybody to know. Either treat it in your hospital or refer him urgently to a hospital where strokes are treated. And it's important to which stroke hospital you refer him to. This is a typical scene from Hyderabad. This is near Begumpet, only 2 kilometers from here. And this is the scene in the morning. And you can see in this traffic jam, there is an ambulance also. So imagine some stroke patient also is in that. And he may waste half an hour in that also. And this is seen on any Indian city, maybe internationally also. So we have to know which hospital we are referring him. So we should refer him to the nearest, not necessarily the best, but the nearest stroke-ready hospital. It's a very good term which has again come from US like everything else. Stroke-ready, which means all hospitals don't treat strokes. We should know in advance. Fortunately, in Hyderabad, most of the hospitals, I would say most of the big hospitals are stroke-ready. They are treating. But you should know where is it, so that it should take minimum amount of time. And it has been recommended now that we should not blindly refer the patient to a hospital. We should notify the particular doctor that I am sending this patient to you, so that there is no in-hospital delay. We have a paper on in-hospital delay. Even in the best of the hospitals, even after patient enters the hospital, he wastes half an hour to 1 hour in going to emergency, waiting at the radiology. Therefore, now one of the criteria is door to needle time is extremely important. Only those are to be the ideal hospitals where you don't waste any time. And it has been shown that in those cases, outcome was particularly better where the receiving doctor was notified prior to the patient arrived that so-and-so patient is coming. So before thrombolizing or taking him to radiology, every physician should look at the airway, breathing, circulation, and whether he is drowsy and all, because it should not that he should deteriorate during imaging and all. That defeats the whole purpose. Neuroimaging is a must because before thrombolizing, we have to rule out mimics and we have to differentiate. This is most important, ischemic from hemorrhagic stroke. And also, imaging gives us an idea about the extent of ischemia and about the depth of ischemia. CT or MRI, you have just now heard excellent lecture. In most of the hospitals, if you take all over the country, CT is the gold standard. MRI is as good or even better at detecting stroke, but MRI should not delay treatment. We should not go by those fancy reports of MRI. We don't want to know lactate pyruvate ratio in an acute ischemic stroke where they give us long reports of MRI. What we are concerned is the time. Time is brain. So if MRI is not wasting any time, in some hospitals, I know Luke Kaplan once had an opportunity, he says the hospital where he worked, there's only MRI available. For CT, he has to get it done somewhere else. So basically, we have to think of time. Wherever you save time, that is the investigation you will do. And the purpose of the imaging in acute thrombolysis is to rule out this, which is a brain hemorrhage. In most of the acute stroke patients, ischemic stroke patients, CT scan is normal, and that's what you want. Or it may show some subtle signs of ischemia, but otherwise practically for everybody it's normal. And if you have a normal CT scan or if you have subtle signs, even if they are all over the CT scan, more than 1/3, you can give it. But what you don't want to have is this black thing here, which is a very dense infarct. Because when there is such a dense infarct, that means either the 3-hour history is not correct. It has happened probably before that, and the patient don't know, or it means patient has absolutely no collaterals, and there's a very severe ischemia, so that it has become hypodense even within 4 hours or so. But in this also, if you have this hypodensity in less than 1/3 of the area, then you can go ahead. Sometimes when we are not sure whether it's a stroke or not, and at that time we may do diffusion, and as has been said before, but otherwise CT scan is good enough for us to go for thrombolysis. And the million-dollar question of is vascular imaging necessary? It is necessary only if we have an interventionist available, or if we have a facility to refer a patient where endovascular intervention is available. If that availability is not there, then vascular imaging only wastes time. It doesn't mean anything for management. For instance, if you see this very nice MRA you are seeing in a patient where MCA is gone, but it takes 10 to 15 minutes to get this image. And if you don't have an intervention list, then there is no need of getting this image. Even without this also you can thrombolyze, or you can do this imaging after you have done IV thrombolysis. Because if it is still there, then you can send him for intervention. So reperfusion strategies are intravenous, intra-arterial or mechanical. But as of current guidelines, intra-arterial has fallen out of favor. Now it is intravenous for everybody, plus mechanical in some. Mechanical in those patients who still have a block in the large artery. But intravenous TPA, everybody has to get, even for those who will undergo mechanical later on. So therefore, it's important to know the indications of intravenous, because all ischemic strokes who qualify will get this treatment. These are the selection criteria. They are the NINDS criteria. They are validated all over the world. It should be a stroke by clinical assessment. patient should have a persistent deficit and NIHS should be more than 4. But now this is changing. People are saying there is no lower limit. Anything which is disabling, you can give it. That is beyond the guidelines. But guidelines say it should be 4. CT scan should not show any hemorrhage. And treatment should be given less than 4.5 hours. It's actually, originally it was 3 hours. But because of one study, which is called ECAS-3 study, it was extended to 4.5 hours. Now, even in US also, you can give up to 4.5, although guidelines still say 3 hours. But up to practically, we can give it up to 4.5 hours. Exclusion criteria are very important. If it's a minor stroke or rapidly resolving deficit, then you may not give it, but it is a relatively exclusion criteria. Patient has to recover completely. If the patient has not recovered completely, if he still has a residual deficit, it is better to give it. Because many times there is still a residual weakness in the hand which remains. So therefore patient has to recover to the extent that he is independent, he is normal, then you can not give it. Otherwise, it's exclusion criteria. Systolic blood pressure more than 185 and more than 105 is the exclusion criteria. Once again, it's a relative exclusion criteria. If you can reduce the blood pressure with the drugs, you can give it. If there are dense infarct on CT scan, which is more than 1/3, this is thought to be exclusion criteria. If the patient is on oral anticoagulants and the PT is more than 15 and INR is more than 1.7, then it should not be given. But if it is less than 1.7 or PT is less than 15, you can go ahead and give it. If the patient has been receiving heparin within 48 hours and has an increased APTT, again, it's a contraindication. You will see this situation particularly with people who undergo cardiology procedures, because they have had heparin also on that day. They get a procedure, then after the procedure they will have their APTT and all can be increased. So therefore you have to check this. Platelet count, if it is less than 100,000. If a patient has a prior history of ICH, subarachnoid hemorrhage or stroke or head trauma in the preceding 3 months, it's a contraindication. Prior ICH at any time, intracerebral hemorrhage or intracranial hemorrhage is what they use the term. If he has at any time in his life, even if it's 20 years before, then it is as per the guidelines thought to be a exclusion criteria. If the patient has undergone a major surgery, GI or urinary tract in less than 14 days, it's thought to be exclusion criteria. If the blood sugar is less than 50 or more than 500, it's thought to be exclusion criteria. Now, most of these, the people who treat strokes, they consider only one exclusion criteria, that means they have brain hemorrhage on CT scan. Otherwise, for most of these exclusion criteria, they go beyond it, take the consent and go, but one has to be extremely cautious about it. I would like to hear from Dr. Qureshi after this, what does he do in these situations. In fact, routinely, it's not necessary to do platelet count or INR or PT unless you are suspecting that the patient has a liver disease, or he's on oral anticoagulants or he has a leukemia and all. Otherwise, it's not necessary. The only blood sugar test you need is blood sugar. And again, it is less than 50 where you have to be cautious. But it is better in these days to make a note of it, and if you are going beyond guidelines, to document why you are doing that. Now, that was up to 3 hours. Now, if you are going beyond 3 hours, up to 3 to 4.5, then the guidelines are subtly, there is some change. One is that if it is more than 25 stroke scale score, NIHS, more than 25, you don't give it. In fact, it's interesting that if it's up to 3, there is no recommendation of NIHSS. Even if NIHSS is 30, there is no exclusion criteria. But if it is beyond 3 hours and 3 to 4.5, and you are still planning to do TPA, then NIHS should not be more than 25. And in this time duration, if the patient is on oral anticoagulants, you cannot give it. Even if it is less than 1.7 and PT is less than 15, still you cannot give it. So probably one tends to get more cautious, in these group of patients who are beyond 3 hours. If there's a history of a combination of prior stroke and diabetes, then you will not give it, because these patients were not included in that trial. And in the original trial, in the original recommendations, upper age limit was not there. You could go to any age. Lower age limit was there, less than 18. But here, if it's more than 80, then again it's a exclusion criteria. A lot of people will disagree with that, because International Stroke Trial 3 showed that you can go even up to 100 years of age. But these are just cautionary notes that when there is something, better to take consent, document it, and go beyond it. Otherwise, one may face into litigation and all. This is the protocol of the TPA, 0.9 milligram per kg body weight. 10% is given as a bolus. As the time is brain, usually that bolus is given in the radiology suite only. As soon as you know that CT is normal, give it there only. Because by the time you take him from radiology to ward, at least in my hospital, it takes another 15-20 minutes. So that's why we go along with the vial to the radiology only. Our residents go with the TPA vial in the hand, and the moment they see while he's in the CT scanner only, they give it. But in that process, sometimes they have forgotten the TPA vials in the radiology suite. And later on, we have to pay for that. Post-TPA care is strict neurological observation. Watch for bleeding tendencies. Minor bleeding, sometimes in gums or little bit nose may happen. Should not worry too much, but you have to observe. No heparin, no warfarin, no antiplatelet agents for 24 hours. And as far as possible, we should not do any invasion on the patient's body by catheter or nasogastric tube or intraarterial catheter for 24 hours, as far as possible. So this is the efficacy of TPA in stroke as per the original NINDS trial. You can see these are all the scales by which you see you measure the patient's neurological function. And this is the percentage normal at 3 months. This is the original slide based on which TPA was approved and licensed. This is the percentage normal at 3 months. And the yellow bar is a TPA and the blue bar is a placebo. And on all the scales, NIHSS, Barthel, Rankin, and Glasgow, you can see that the TPA group is clearly statistically significantly superior to the placebo group. And therefore, if we extrapolate it, the net benefit of TPA is that for every 100 patients treated with TPA, 13 more patients will achieve independence at 3 months. Right? So once again, this is important while counseling the patients and while telling them. But although the present guidelines are that you can give TPA up to 4.5 hours, but it is recommended that you should give it as early as possible. You should not wait for 4.5 hours, that there is still time, there is still time. We should not have that mindset. The moment patient comes, we should try to give it. This is a very famous slide which is projected in every conference. People who receive at 60 minutes or at 1 hour, this is their odds ratio of favorable outcome at 3 months, almost 7 times. And as the time goes, this becomes less. And at about 3 hours, it's much less. And at 4.5 hours, it is still less. So even though the window is 4.5 hours, we don't have to wait for 4.5 hours, which we initially used to do. We used to tell patients, okay, you can think about it. You have still 1 hour. And by the time he would call his cousins in New Zealand and America and all, and then we also would be relaxed. And then as 15 minutes would be remaining, now you tell. Now you have only 5 seconds left, tell me. Like, 1, 2, now you cannot give it. So it has been shown that that is a very immature way of thinking. And basically you can give it even beyond 4.5 hours also. But message is earlier the better. We should not wait. Earlier the better. Now the main problem and the bugbear with the TPA is that you cannot promise anything to the patient. I think I'll personally get a heart attack someday because of this thing, this decision making, this commitment to the patient. Will he improve or not? It's totally unpredictable. You can make guess and all, but you cannot promise. But I think that is one of the reasons why it has not picked up as much as it should have. Like IVIGs have picked up. Everybody gets the IVIG because it is safe that way. We have also been studying, this is one of the theses of which finally became a paper, predictors of neurological improvement after IV TPA in acute ischemic stroke. And like everybody else, we also found that if you are age less than 60, and if it's a mild to moderate stroke of NIHS 10 and the blood sugar is normal, then these are good predictors of improvement. And usually the patients who improve, they show that improvement in the first few hours only. Many times they show within 1 or 2 hours. And by 24 hours, you know this patient is improving. Although interestingly, in the original TPA study, the significant improvement was detected only at 3 months, not at 24 hours. But in practice, we are seeing the patients who have to improve, we know by 24 hours they are going to improve. Okay. And other thing by which we can predict to some extent is that if you see this hyperdense artery here, which you are saying hyperdense MCA, these patients may not recanalize following intravenous route. These are the ones where you have to consider that you may have to go by endovascular. It is not a very good predictor of recovery. On the other hand, if you have got there's a very small dot, which means it is M3 or M2, which you are seeing here, these do relatively better. So on CT scan itself, if you see there is evidence of large artery, as you can see by the arrow here, this may mean this patient may not do well. So therefore, for the last, people have noticed this thing about 10 years or 15 years ago. So many trials were done, and but nothing came positive. And I think Vikram Hooded is here, and we really battered him 3 years back. And we thought all intervention is closed and nothing will happen. The days of intervention are over. Neurologists were very happy that now we don't need them and IV is good. But last year was a comeback for the interventionalist. All these trials, ESCAPE trial, Stroke Clean, Swift Prime, Extend IA, they all showed that for selected patients of stroke who have got large artery occlusion, endovascular treatment along with IV TPA is clearly better as far as the outcome is concerned. So last year was an excellent year for the endovascular interventionalists. So conclusion of all these trials in last year was that IV TPA and mechanical stent thrombectomy should be standard of care, no longer experimental. And in patients with vessel occlusion and salvageable brain tissue, which means they have a small core on CT or MRI, this leads to early neurological recovery, better functional outcome with no safety concerns. So therefore, as a bottom line, if we have interventional facilities, either in our own hospital or in a nearby hospital or in a referral hospital, then after having diagnosed stroke, we must make sure that all patients should get IV TPA, all stroke patients should undergo vascular imaging either before or after IV thrombolysis, and those who have vascular block should be subjected to mechanical clot retrieval only by solitaire device, because evidence is only on that particular disposable stent. There are many kinds of devices, but the evidence is for this. Tomorrow, Dr. Padma and others are going to talk in detail. I think Dr. Adnan Qureshi is a world leader. They will discuss this in detail and we'll learn about all these methods. Now, this is the main risk of IVTP, of which all of us are afraid. Brain hemorrhage happens in about 6% of people. And these are thought to be predictors. If it's a big stroke, if patient has more than 80, high diastolic blood pressure, high blood sugar, and gross ischemic changes in CT scan. Having said that, there are some patients where hemorrhage still occurs, even if they have none of them. So hemorrhage is a reality which will happen in every 13th or 14th patient, and we have to accept it. It is a trade-off once we give it, and many times patients, you don't know why the patient had a hemorrhage. But what has been shown by evidence is that adherence to protocol minimizes bleeding risk and also optimizes the long-term outcome. I think Calgary and other studies are there that as far as possible, adhere to the protocol. And if you do that, you will minimize the chances of bleeding and good outcome. So this is our national icon, Amitabh Bachchan. And in the movie Zanjeer, he's a very honest police officer. I don't know how many of you have seen this movie. And then he realized that being an honest police officer, he cannot kill all the criminals. And sometimes for killing the criminals, you have to break those guidelines. Because you cannot follow rules always. So in next movie, he becomes Kalia. And he breaks the rules. But important is for the good of the patient. I would not encourage any one of you to break the rules. And even when you break the rules, it should be for the good of the patient, which I here mean by documentation. I think younger blood, there are some younger, they always want, no sir, we can do like that. No sir, you are unnecessarily afraid. I said, but please document it while we are doing it. Because there can be litigation when a patient doesn't do well. So if we have well documented, then we can go ahead with it. Okay. So one of the criticisms of TPA was that there was too much of rigidity. This was realized in US also. There's too much, this paper came in 2007. And they said because of this rigid time window, so many don'ts and all, it could not become popular. So this was a very nice paper beyond the guidelines and in particular clinical situation in stroke. And at the time it said that it is not just the NIHS score, that score is not important, it is the origin of the score. So it is not just 3. If that 3 is coming from aphasia, it's a disabling deficit. Even if it is 3, it should be given. Even if it's 2, it should be given. So aphasia, neglect, hemianopia can be given. And now people say that the Pooja Khatri is doing one very important study, that even if it's a minor stroke, which means that even if it is a hand wrist drop, it is also a disabling stroke. So lower limit, there is no lower limit. You can use your judgment and give it, but please document it in the case sheet. Post-MI was thought to be a contraindication, and now people say, because there was a fear of myocardial rupture and a fear of pericardial hemorrhage. But usually it is seen that this does not happen in the first day. This risk is mainly on the second day. So if you do an echo and echo is not showing any pericarditis or pericardial effusion, and if there is no major wall motion abnormality, you can go ahead and give it. Seizure was thought to be a contraindication because it was thought by mistake you may give it to Todd's palsy. But if you are sure that the seizure is related to ischemia by your imaging and all, then I think it is allowed to give. Patients less than 18, more than 80 also you can give, but documentation is important. Pregnancy for quite some time, first few years it was not sure, but now it is thought to be safe in pregnancy. And during menstruation also some patients were declined TPA in the initial years, but now it can be given. As a matter of fact, all these things which was thought beyond guidelines few years are no longer thought beyond guideline. In the advisory of last year, 2014, you are allowed to give them. It is no longer breaking the rules. This is part of the rules. But only thing is we have to just document it in the case sheet. But what to do if the patient comes beyond 4.5 hours and all, can you still give it? You heard excellent lecture by the radiologist. You do this technique, diffusion, perfusion mismatch if it's available. It is still not validated. It is still experimental only, but the principle is that if you see a diffusion, as you can see here on the right side, but perfusion area means where there's a vascular insufficiency, but it is not permanently damaged. So this is a mismatch. If there's a mismatch, and even if it's at 5 hours or 6 hours or 8 hours, you still have chances that the patient may improve because there is some salvageable brain. This is one technique, diffusion, perfusion mismatch. And these are some other things which are written in papers. The diffusion clinical mismatch, which means clinically if a patient is a severe stroke with a hemiplegia, dysarthria, visual field cut, NIHS coming 12. But on imaging and diffusion, you don't see so much of damage there. That is very small. And in fact, based on this hyperintensity, you should not get visual field cut and all. So it is thought that lot of deficit here may be because of dysfunctional rather than dead tissue. It is dysfunctional rather than dead tissue, so you can take your chance and give in these patients also. It's called diffusion. These are not in guidelines, please. They are going beyond the guideline. And you can see in this patient, if he was not given TPA, eventually it became a big stroke. And then there is one more which our radiologist talked, diffusion flare mismatch. It's usually in those cases where you are not sure when the stroke happened. It's based on the principle that flare abnormalities do not come before 4 hours or so. So therefore, if a patient shows you abnormality in diffusion and flare is normal, then you can assume with a reasonable degree of certainty up to 90% that this stroke has probably happened in the last 4 hours. It is not 100%, but it gives you an idea. Diffusion flare mismatch, particularly helpful for wake-up strokes when you are not sure about the onset. So this is the AHA 2015 guideline, which came as a supplement to the 2013 guideline, that all patients of acute ischemic stroke should be considered for intravenous TPA if they meet the guidelines. This is class 1 level A evidence. So we have to consider them. Everybody will not qualify, but those who will qualify, we should give them the advantage. Patients eligible for IV TPA should receive RTPA even if endovascular treatments are being considered. That means even if you know that he has got a large artery disease and even if you are planning, still the first thing you will do is to give him IV TPA. It is possible that some of them may recover with that IV TPA. 30% of large arteries also can dissolve with IV TPA. We have had those experiences if the clot is soft or recent and all. So IV TPA is absolutely to be given, irrespective of the fact that you may give on top of it intervention. So these were the new guidelines added last year. But this is just a summary. Basically, tomorrow you will hear about it. That patients should receive endovascular therapy with a stent retrieval if they meet the following criteria. These are the ones where you have to consider endovascular. First of all, they should have received IV TPA. That is actually a criteria. They should have received IV TPA. Causative occlusion should be in the internal carotid artery or proximal MCA, which should be documented by the imaging. Age should be more than 18 years. NIHS score of more than 6 and aspects should be more than 6, and treatment can be initiated within 6 hours of symptom onset. I'm sure we'll have a lot of discussion and debate on all these points tomorrow. So please don't be afraid of IVTPA. It is something which has to be done in everybody. Thank you very much.
Any questions?
Questions or comments, because many of you are experts. Yes, sir. Yes, sir.
Thank you, Professor Kaul, for an excellent lecture. I have a few comments to make. I'm Dr. Hegde from Bangalore. I'm a neurosurgeon by profession. First of all, we all agree that if the diagnosis is made early, then the outcome is good. But one of the problems has been that these lesions are painless, especially the ischemic one. The patient decides to come the next morning. Unlike in heart attacks, where they rush to the hospital. Is it practical for us to frighten the patient like something like cancer, painless tumor? Similarly, link it to something which is more frightening and do the health education according to that, which may be beneficial, I feel. The second thing is, I always wonder the role of vasa vasorum. Whenever there is in cerebral vessels, you generally don't see vasa vasorum, except when they are dilated or aneurysmal formation is there. Because this I noticed while trying to clip a fusiform dilatation of vertebral artery, and I had coagulated the wall. By next day, the whole thing had thrombosed. I don't know what is the connection between the two, but that's one of the things that I'm frightened to do after that. Dr. Qureshi mentioned about acute collateral development. Obviously, there are two types of collaterals. Acute, what you mentioned, and like in Moya, chronic ones. Now, the acute ones, I think, are self-limiting. It's a short period of time. They give time for the surgeon or the physician to do what treatment is necessary.
Can you be brief, please?
I think all points are well taken. Yeah.
But also further supports what you were saying about mild strokes. And sometimes, there's a lower bleed risk with treating mild strokes. Mild strokes can sometimes be very disabling, but also when you assume that the mild stroke will stay mild and then the patient gets admitted and those collaterals fail, then it becomes a moderate or severe stroke. Sometimes that can happen overnight and you miss that window. So that's a further reason to suspect that some of these mild strokes may further expand and become more severe because of collateral failure. And the other good point that you brought up at the end, neuroprotection. Yeah, I was part of a large multi-center trial, the FASTMAG trial, looking at magnesium and neuroprotection. But I got to learn a lot about different neuroprotective agents, and I think there have been a lot of trials for neuroprotection, but they've done really well in rats, but hasn't really translated into clinical trials into humans. But definitely, I think there's a lot of research and hope that there'll be cocktail therapies, combination therapies for cerebral conservation in some manner, freezing the brain to allow extension of the time window for treatment. So that is something that I think is still in discussion.
Yeah, please. Doctor.
Patient who develops significant intraparenchymal hemorrhage following IV TPA and which requires a decompressive surgery, how do we prepare the patient for a procedure if he requires one?
See, usually decompressive craniectomy can be done because as far as this TPA is concerned, within 2 or 3 hours or even 1 hour short. So there is no contraindication to doing a decompressive craniectomy. But we do, actually, ideally speaking, we have to do their fibrinogen levels. And we have to correct it by cryoprecipitates. But in practical terms, we just give fresh frozen plasma, as we would do in any bleeding. We give him 4 to 5 fresh frozen plasma, and if there's a midline shift and all that thing, we undergo decompressive craniectomy. That's not a contraindication.
Is there a time frame, time period which we have to wait for before we...
Adnan Qureshi, is there a time frame?
The half-life is 3 to 6 minutes.
No, he wants to know, is there a time
frame for endovascular treatment?
No, not endovascular, decompressive craniectomy. If a patient gets a bleed, if he needs a decompression after TPA, suppose there's a bleed, then is it safe to do it, and how early can we do it?
You mean a craniotomy to remove
craniotomy?
Yes.
Yeah.
So essentially from a safety perspective, the TPA, the half-life of alteplase is only 3 to 5 minutes. So essentially if you were going to operate 24 hours later, you shouldn't really have any anticoagulant activity. I would actually say that even 12 hours later there should be no thrombolytic activity that's persisting in the system. But the question really is that whether craniotomy really helps the outcome of patients who have post-thrombolytic intracerebral hemorrhages. And the answer is that evidence does not exist. In fact, one, it's actually rarely done, and even if you look at the patients who have actually had surgical evacuation for post-thrombolytic intracerebral hemorrhages, their outcomes don't seem to be good. So I think that the bigger question is whether it's actually something that really helps or not. The other thing that you can do if you think that craniotomy is something that needs to be done, you can actually reverse part of the thrombolytic activity by giving them aminocaproic acid. So that's actually still an option to use if craniotomy is being considered.
Thank you, sir.
I think we'll close the session because we are short of time. Thank for all the speakers and for active participation from the floor, and we will have a break for tea and then assemble by 11 o'clock.
Country knows him. It's known internationally also. Many of his students are here, and he is also like me from my alma mater PGI Chandigarh, and he has done a lot of work, research work in almost all fields. Although epilepsy is something which he loves and does, but he's also interested in practicing whole of neurology. Stroke is also one of the passions, and he runs a critical care unit. In fact, he is the first one in our state and one of the first in the country who ran critical care in neurology, and for many years he did critical care conferences, first time in our country. So it's our pleasure to invite Professor Murthy to talk on a very difficult topic of intracerebral hemorrhage.
Thank you so much. At the outset, I would like to thank Dr. Nabil to involve me in this great workshop and meet. Intracerebral hemorrhage is a subtype of stroke, and a serious type of stroke, or rather I would say a dreaded clinical syndrome with no known effective treatment. The incidence reported from USA is 15 to 40 cases per 100,000 patients, and second most common form of stroke. Coming to our country, the reported incidence in the WHO STEPS study in 3 cities, the incidence is anywhere between 13 to 32%, and that 32% is from the northeast of the country. It accounts for 10 to 15% of first ever stroke with an higher incidence in the Asians. There is some genetic predisposition. Similarly, the incidence is high in African Americans also, 20 to 30%. Basically, when we say primary intracerebral hemorrhage, the etiology is two, that is hypertension. Most of them are due to hypertension, about 2/3 of it, and then comes cerebral amyloid angiopathy. When to suspect cerebral amyloid angiopathy is when the patient is elderly and the distribution of hemorrhage is in the occipitoparietal and more peripheral, and often susceptibly weighted imaging will show more than microbleeds. The risk factors for hemorrhage is hypertension, male sex, age, ethnicity, as I have already said, Asians and African Americans, smoking and alcohol consumption. It is associated with high mortality and morbidity. 30-day mortality is even up to 50%. Half of the death occurs within 48 hours of onset of the disease. The median 1-month case fatality rate is about 40%, and those who survive, only 12 to 38% achieve good functional independence. There is some earlier studies from St. Louis. Deringer is my introduction to neurocritical care is through Deringer. Their study clearly shows treatment within an ICU can decrease mortality in patients with primary intracerebral hemorrhage. The important predictors of 30-day mortality is level of consciousness, intracerebral volume, location, particularly infratemporal location, interventricular location, and age. And this is a well-validated study by Hamfield, and which gives a surrogate marker for the predicting mortality. And there is a linear relationship between the score. The lower the score, the less the mortality, higher the score, almost 100% mortality. And the important and robust predictor of mortality in intracerebral hemorrhage is the volume of hematoma. This is the very good study by Broderick, and it clearly shows any volume more than 30 ml is associated with increased mortality and morbidity. And the other important predictor is hematoma growth. About 38% of patients will have growth of hematoma that is more than 33% compared to basal hematoma volume occur within 3 hours of onset, and 26% within 1 hour of CT scan, and additional 12 within 1 to 20 hours. Hematoma growth is associated with neurological worsening of neurological deficit as well as mortality. And this is the data, meta-analysis of the pooled data of all the 3 studies, placebo arm of that activated recombinant factor 7 data. It clearly shows for every 10% increase in ICH growth, there was a 5% increased risk of death, a 16% increased risk of worsening outcome as measured with modified Rankin scale, and an 18% increased likelihood of being dependent or poor outcome on Barthel's thing. So all these data clearly suggest hematoma growth is an important predictor and robust predictors for poor outcomes. So one of the targets can be to prevent hematoma growth. These are the data from mostly from retrospective study, except the spot sign, that observational studies and retrospective studies, various predictors have been found. And of these, spot sign has been well studied, and the other is initial large hemata volume. These two have been relatively well studied. And this is I took the pictures from Kim's paper. It's clearly, okay, you see there is this is a plain scan, thalamic bleed. And clearly contrast scan shows spot, that is extravasation of blood from bleeding vessel, and then it is associated with the expansion in the last picture. The active contrast extravasation on CT, that is spot sign, in patient with primary intracerebral hemorrhage independently predicts hematoma growth and mortality. Several studies have confirmed these findings. The other predictor is initial hematoma volume, and this is a elegant. What we do in this is you take basal volume scan and the time to imaging, onset to imaging time, we take it, and initial volume divided by the time, and the ultra early hematoma growth more than 10.2 ml per hour emerged as the most powerful predictor hematoma growth, early neurological deterioration, 3-month mortality, and poor long-term outcome. And those patients who had spot sign, they had a rapid expansion of the hematoma. So we know these predictors. Can we modify any one of those things? Because as we know that hematoma volume and its expansion in the first few hours is associated with mortality and morbidity. So stopping or slowing the initial bleeding, that's one target. Removing blood from the parenchyma or ventricles, that's the second target. Management of complications, intracranial pressure, and thereby improving cerebral perfusion pressure. General measures like stroke as. So the one which is tested and which has been shown to have a biological effect is the activated recombinant for factor 7. In the proof of concept study, Stephen has shown that there is a dose-dependent biological effect in reducing the hematoma growth. But when it came to phase 3 trial, fast trial, no functional and survival benefit despite showing statistically significant reduction in hematoma growth in recombinant treated patients. Possibly one of the possible explanation is more severe patients have been allotted to treatment arm. Post-hoc analysis of the data suggests potential benefit in young patients, that is aged less than 70, hematoma volume less than 60 ml, intraventricular extraction, hematoma volume less than 5 ml, if given within 2.5 hours of the onset, that is before the hematoma expands. Those are the patients, subgroup of patients who are likely to be benefited. But unfortunately, this study, nobody is coming forward to sponsor, to see the effect of factor 7 in this subset of patients. Blood pressure, elevated blood pressure is an important factor for the growth of hematoma. There are several studies. One of the reviews by Dr. Adnan Qureshi clearly shows the mortality in good blood pressure control, earlier studies. Then that led to the two important studies, INTERACT and ATTACH studies. In ICH, both the relative hypertension and continuous sustained hypertension could be deleterious. About 70% of patients with ICC have systolic blood pressure more than 140 millimeters of mercury within 1 hour of presentation. Elevated BP on admission or within the first 24 hours is associated with increase of death or disability. This is related to hematoma growth. Elevated BP has the strongest association with hematoma expansion. INTERACT 1 study clearly shows by effective controlling the BP, keeping the systolic blood pressure around 140 millimeters of mercury has a biological effect. It reduced expansion of hematoma growth, 60.2% versus 16 points. In ATTACH study, they have 4 groups. I think Dr. Adnan Qureshi is the principal investigator of this study. He will be adding more information on this study. Both the studies showed that effective control of blood pressure or aggressive control of blood pressure is safe in patients with intracerebral hemorrhage. Based on INTERACT 1 findings, the Australian group, multicentric and involving multiple countries, they have done INTERACT 2 study. Unfortunately, it didn't show much benefit in terms of mortality between the intensive group and guideline, that is bringing down the systolic blood pressure to 144 within 1 hour of admission or within 6 hours and maintaining it like that. Non-fatal serious adverse events are similar. However, when they did ordinal analysis, which is a pre-specified endpoint, the ordinal analysis of modified Rankin scale showed significantly lower MRS with intensive treatment arm. Intensive group had significantly better overall health-related quality of life at 90 days than guideline group. That is, in that guideline group is the systolic blood pressure was kept around 180. The conclusion can be acute BP reduction to a target systolic blood pressure of 140 millimeters of mercury or less appears to be a reasonable option in spontaneity. We are part of this study. These are the recommendations by American Heart Association and American Stroke Association. Basically, the concept is keep the blood pressure at a reasonable level, systolic blood pressure, and the guidelines thing. But these are the guidelines before the INTERACT 2 study. The other important complication of that means essentially the only treatment that we can opt to reduce the expansion of volume of expansion of hematoma is keeping the blood pressure around 140. That too, there should not be fluctuation. One of the factor noted for lack of benefit of reducing the blood pressure is wide fluctuations of BP and during treatment period, and also the treatment of blood pressure. Several drugs have been used based depending upon the center and their practices. So what I suggest is, that is our practice, we keep 140 millimeters of systolic blood pressure within 1 hour of admission, and we try to keep the blood pressure smooth without much of fluctuations. Then the second important feature where there is complication is acute seizures. The incidence of clinical seizures within the first 2 weeks ranges from 2.7% to 17%. Continuous EEG monitoring by Paul Vespa group reported electrographic seizures in 28 to 31% of patients. I will show you later what is the influence of these electrographic seizures on hematoma volume. Occurrence of early seizure does not influence outcome at 6 months. Prophylactic age is not indicated and may be harmful. I will put data not from ICH but in subarachnoid hemorrhage group patients. Clinical seizures should be treated. This is Paul Vespa's study. There is definitely those patients who had seizures with ICH. There is the final NIH score is worse when compared to those with non-seizures. And there is a trend towards increased poor outcome in patients with thing. And they are also shown midline shift. Patients seizuring increasing in poor outcome and also it resulted in midline shift. This is not the data from, this is the data from subarachnoid hemorrhage group, prophylactic anti-epileptic drugs or anti-convulsant drug. Because I am just, the same thing may happen in intracerebral hemorrhage also. That's why I am putting the data of in regard to phenytoin. Phenytoin use is associated with fever. Fever is associated with poor outcome for any acute injury, brain injury. Fever has a deleterious effect. Higher fever and longer fever duration, that is fever burden, predictive of poor outcome after subarachnoid. I'm just telling these things, same thing may happen in ICH also. Burden of exposure to phenytoin as measured by serum levels has been shown to be associated with worse functional and cognitive outcomes in dose-dependent fashion. So I will see if you want to give, the presumption is seizures may alter the intracranial pressure dynamics and may worsen the pressure. That is the presumption for giving prophylactic anti-convulsant drugs. But I personally feel in our neuro-ICU we don't give prophylactic convulsant. But when we treat, patient has seizure, we treat it and the drug of choice is levetiracetam. The next thing is remove, there is a volume, additional volume added to the intracranial volume, so which is likely to result in raised intracranial pressure and compartmental shifts and herniation and death. So can we do something? We remove, the best option is to, theoretically the robust rationale is to remove the extra volume. So the STITCH study clearly shows there no benefit, both in terms of mortality as well as morbidity. But again, the Cochrane review suggests there is about 1/4 of the patient from the placebo arm, that means non-surgical arm, have been shifted to surgical arm because of deterioration by the local treating surgeon. That is one of the limitations that might have been influenced the final results. And as far as AHA and ASA guidelines, surgery in ICH has definite role in cerebellar hemorrhage more than 3 centimeters volume, who are deteriorating neurologically or who have brainstem compression and are hydrocephalus from ventricular obstruction. Class 1 recommendation level B evidence. For patients presenting with lobar clots within 1 centimeter of surface, evacuation of supratentorial ICH by standard craniotomy might be considered. Class 2B and level B evidence. This is based on the stitch study. Those patients who had superficial hematomas, who had surgery, they did better. That's why they did stitch 2 study in this group of patients. Unfortunately, that study also didn't show any benefit. The other is decompressive craniectomy. We did a study, and it is highly selected patient, young patients with large hematoma, with no much comorbidities, and clearly shows we could salvage some of the lives and the functional recovery is better. The other predictor of poor outcome or death is intraventricular hemorrhage. About 40% of the patient with ICH will have intraventricular hemorrhage. Here I would like to mention it. Initial scan may not show IVH, but if you repeat it within 24 hours, about 20 to 30% of the patient can have IVH. So it is better to repeat the scan. Anyhow, we will be repeating the scan. Our protocol is to repeat the scan whenever there is deterioration or when after 24 hours to see the expansion of hematoma. 20 ml is considered as lethal volume. 30-day mortality with ICH plus IVH 43% versus ICH alone 9%. Volume of IVH, presence of blood in more than one ventricle and hydrocephalus are associated with higher mortality. Survivors often have a severe neurological and cognitive disability. In recombinant factor 7A trial, good outcome in patients without IVH was 43% compared to 20% in those with IVH, suggesting clearly it's a poor, very bad prognostic marker. Ventriculostomy to monitor ICP is and titrate ICP treatment, and drainage is indicated in when the patient has GCS score less than 9, clinical evidence of transtentorial herniation, significant intraventricular hemorrhage, acute hydrocephalus. There is a benefit to the stitch. I think stitch 1 subgroup analysis has shown intraventricular hemorrhage, there is a trend towards better outcomes. EVD in patient with IGH with severe IVH and obstructive hydrocephalus with altered mental status. Intraventricular fibrinolysis with urokinase or TPA, that is clear study, is on, has been shown to promote early and effective clearance of blood from the ventricles, maintain EVD functionality and reduce the need for permanent shunt, improve functional outcomes and reduce mortality. Based on these things, this clear study is being initiated, giving 3 milligrams of TPA at 12-hour intervals till the ventricles clear of blood. And the other surgical intervention is the minimally invasive surgery plus TPA in intracerebral hematoma evacuation. Proof of concept surgery or concept studies are underway. The other important factor which may contribute for deterioration, it may not have it may not be independent risk factor for mortality, but it's a clinical situation which needs emergent treatment sometimes. This is one of our patients who developed massive perihematoma edema, and we did decomprensive craniectomy, and he survived, but with functional deficit. In Interact 1 study, the degree of and growth in perihematomal edema are strongly related to the size of the underlying original volume of acute ICH and do not appear to have a major independent effect in determining the outcome from this condition. So, but sometimes it will be very severe. We have around three patients. Recently, about 2 months back, we have a patient who developed much later edema, and we as a life-saving procedure, we did hemicraniectomy with duroplasty, and he survived. Survival benefit. Temperature is very important factor, and it has deleterious effect in any patient with acute brain injury, including intracerebral hematoma. There are two trials going on: target temperature management after ICH, TTM ICH, ultra early treatment of temperature normothermia versus mild induced hypothermia. Trials are going on. Same way, another trial regarding temperature management is cooling in intracerebral hematoma. SYNCH trial is also underway. So, I reviewed some concepts. So, still the robust predictor of poor outcome is the hematoma volume expansion, and the best thing is we need to find a management protocols to reduce the volume expansion and to see whether we can remove the extra volume added to the intracranial volume. In surgery, stitch style failed to show any positive effect, but maybe minimally invasive surgeries with addition of TPA may show some beneficial effect. So as I said in the beginning, this is a dreaded type of stroke. Still we don't have a proven effective treatment. Thank you for your listening.
Thank you, Dr. Murthy, for a very comprehensive update on intracerebral hemorrhage. Any questions or comments? Yes, sir. Can somebody pass on the mic to him?
Regarding this intraventricular hemorrhage, how can we evaluate or measure the intraventricular blood volume?
Same ABC
As
we
of
measure the volume of parenchymal hematoma, same formula.
Sir, is there any potential risk of shooting up of BP when we are actually inducing the hypothermia?
Shooting of blood, we take care of that aspect. I'm not aware whether temperature influences when we are reducing the temperature. If at all, it should drop. I don't think it shoots up. Dr. Adnan?
You mean the systemic blood pressure? I don't think that it's consistent. I mean, I think sometimes because of the sympathetic overdrive that actually occurs as a consequence of hypothermia, you may see some change, but definitely not a consistent one.
Thank you for comprehensively reviewing about the management of ICH, which is a tough disease. Now I got one question, that's intracerebral hemorrhage, irrespective of the size, the degree of the hypertension severity dictates the outcome. I want your comment on this, number one. Number two, in patients of intracerebral hemorrhage, moderately large, still to be on the bed, in second week they develop a DVT. How are you going to approach these patients?
Coming to the first question, as I told, some amount of elevated hypertension, elevated blood pressures are very common in the acute phase of intracerebral hemorrhage. So your question is intracerebral hemorrhage and IBP. Can you repeat that?
What we found is patients with intracerebral hemorrhage, when they present with very high blood pressures, they do badly. We feel a patient with intracerebral hemorrhage with probably hypertensive crisis-like situation worsens the outcome when compared to a intracerebral hemorrhage with moderately high blood pressure.
So the blood pressure, high blood pressure increases, results in the expansion of the hematoma. That may be variable which determines the outcome. So we need, at present the data suggests that we need to keep the systolic blood pressure around 140. That is beneficial in long run. It may not have immediate biological effect in the form of reduction of 30-day mortality as well as morbidity. But high blood pressure in intracerebral hematoma, in admission high blood pressure has a deleterious effect. It predisposes for the hematoma expansion. Coming to the DVT prophylaxis, we know from various studies that hematoma expansion occurs maximum within 4 hours. And beyond that, the expansion, that means continuous bleeding, is very less likely. So our protocol is we usually start after 48 to 72 hours in patients with high risk for DVT, and we prefer unfractionated heparin because we have, if there is anything that goes wrong, we have a protamine to reverse the anticoagulation effect. And we will go to this sequential compressive devices. Mostly we apply that.
Any other comment? Yes, please. Please, can you give?
So there are 3 questions actually. One is that any intracerebral hemorrhage having interventricular extension, I mean the idea of putting a EVT and injecting TPA as we do in a primary interventricular hemorrhage, it does work in my experience in 2 patients, but it's quite double-edged sword and dangerous. Your comment?
Now we have some experience with the protocol based 3 milligrams at 12-hour interval. We will install and then drain after 12 hours, again install, drain till it gets clear.
There was an idea from one of the neurosurgeon colleague, to put a endoscope inside the lateral ventricle and
draining also.
Draining also, and do a ventricular lavage.
Yes.
Doshi from Jaslok, he does it very frequently.
The next question is that as Dr. Qureshi has told, amino caproic acid for this controlling of TPA-induced hemorrhage. But tranexamic acid, I think there is some literature that it does work in intracerebral hemorrhage as well as in TPA-induced intracellular hemorrhage.
It is now it is coming back in subarachnoid hemorrhage, in poor grade subarachnoid hemorrhage, where you want to delay surgery for a short course of both tranexamic acid, aminocaproic acid. They are being used, but I am not sure any trial with ICH. Dr. Agnew?
Yeah, I think that there is some anecdotal evidence, but it's clearly not enough to say that it's effective or not. I think one can say that it's feasible and relatively safe to use aminocaproic acid and similar compounds in post-thrombolytic hemorrhages, but I don't think we have the evidence that it really makes a difference in outcomes.
The last one is that when we use mannitol in a patient who is having ICH with mass effect, not fit for surgery or not willing for surgery, do you prefer hypertonic saline if patient is having SIADH, which will work for both the things? SIADH. I mean a patient who is having intracerebral hemorrhage with a mass effect, we use mannitol, but there are reports that hypertonic saline can be used as a reducing intercranial pressure.
So there is coming to hypertonic saline, it maintains the advantages with the hypertonic. It maintains sustained osmolality so that fluid shifts can occur at a sustained fashion. And another thing is, it doesn't have much of renally related issues. The third is, even though it is mentioned coagulation effects and other things, we haven't seen, we use quite a bit of 3% saline in our NICU. We don't see, we use very little of mannitol. But there are no head-to-head comparative studies to say which is superior thing. Both work, but we feel our preference is for 3% saline. And coming to hyponatremia and thing, there is a beneficial effect. You can correct it, but be careful, because when we give 3% saline, we give to keep, the goal is, target is to keep the sodium at least 150 milliequivalents. So if we try to achieve that, we may result in a patient with hyponatremia, we may end up in asthmatic demyelination syndromes. So we generally avoid it. There is a theoretical benefit, but when you want to do rapidly built up to as an asthmatic agent, 3% saline, then there is a risk of asthmatic demyelination syndrome in a hyponatremia patient.
Thank you, sir.
Yes, sir.
Angiogram recommended in a select group of patients with intracerebral hemorrhage with hypertension, and if so, whence?
By definition, if you think it is intracerebral hemorrhage primary, only condition when you get some doubt when it is lobar hematoma. Deep-seated hematomas like putaminal ganglionic hematoma, thalamic hematoma, brainstem hematoma, cerebellar, I don't think in a patient with hypertension we need to do angiogram. Sometimes isolated lobar hematoma, if you have some clinical suspicion, CT angio can be done, which is safer. And it has a high sensitivity and specificity to pick up aneurysms and as well as malformations.
I just wanted to make a quick comment about the and intracerebral hemorrhage. And essentially, 2 decades ago, there was an article that said that there should be a scientific half-life or a half-life of scientific medical truth, which meant that everything that we know in 25 years, half of it will be proven wrong, and if we wait 50 years, all of it will be proven wrong. And the story of blood pressure treatment in intracerebral hemorrhage is an example of that. And I think Dr. Murthy and Dr. Kaus will remember that there was a time more than 2 decades ago where the thought was that there is ischemia around the hematoma. So the hematoma, by compression of surrounding microvessels, creates a zone of ischemia. So blood pressure should never be lowered in intracerebral hemorrhage. And then it started, people started recognizing there was this hematoma expansion phenomena, and perhaps hypertension contributed to that phenomena. So then people started talking about modest blood pressure reduction. And then modest blood pressure reduction was shown to be safe. And then people started arguing the concept that maybe if some is good, more may be better. And now we are actually talking about intensive blood pressure reduction. So that's what INTERACT-2 and ATAC-2 were actually looking at, is actually not just modest blood pressure reduction, but intensive systolic blood pressure reduction. The other concept of this hypodensity around the hematoma that you see on the CT scan, and actually that being edema is what the concept is, that it just represents vasogenic and cytotoxic edema around the hematoma. But nonetheless, in most studies, that volume of that hypodensity doesn't correlate with outcome. And recently what we did was we did a study where we just injected blood in dead brains, and you can see a hematoma form, but then you follow them with serial CT scans, and you can see the hypodensity develops even in dead brains. So clearly it's not a biological process, it probably is just more of an exudation and retraction of the existing hematoma. So I think that in part represents the lack of prognostic significance of that hypodensity around the hematoma.
That may be true for the early perihematomal edema, but late, like which I have shown, it is related to RBC lysis and matrix metalloprotein 9.
Yes, sir. Okay, sir, if you permit, I can ask one question for my own guidance. I used to always ask you today. As far as the guidelines, if we go strictly by the AHA guidelines and evidence-based medicine, then you will agree with me that this mannitol and even other decongestive therapy is not proved and has no role. Even neurosurgery in these patients of basal ganglionic, massive infarcts have no role. So a typical scenario, emergency, one patient comes with massive hemorrhage, our residents start mannitol and give a neurosurgery consultation, both of which are wrong. But what else we do if not that? I want to know from you.
Control the blood pressure.
That's all.
And then take care of other comorbidities and glucose, seizures.
So even if he cones in front of us, we'll just, practically I'm asking you.
That's why I said it is a dreaded disease with no proven treatment.
Yes. You have any comments on that? What do you do in America? When a patient of brain hemorrhage pressing the ventricle, you just watch him from distance or still do something?
So I think that, the concept of surgical evacuation, I think multiple trials have shown that as we practice surgical evacuation, doesn't seem to make a benefit. In terms of hyperosmotic treatment, unless the patient is actually showing signs of transtentorial herniation, just radiological mass effect, I don't think is enough indication to start hyperosmotic treatment. I think that more and more concept is that, perhaps we are overusing mannitol or even hypertonic saline. So I think we have to more restrict it more. One interesting fact that, some people may know is that in the STITCH trial, when they actually looked at the outcome of patients with intracerebral hemorrhage according to countries, the country that actually had the best outcome of patients with intracerebral hemorrhage in the STITCH trial was India.
India.
Yes.
So you want to make a last comment? Yeah, it's the very last. Short. Yeah.
Situation, atrial fibrillation on anticoagulant, oral anticoagulant, carotid artery disease on antiplatelet agent, intracerebral hemorrhage. Your comments and guidelines with regard to the dose adjustments.
If it is, are you talking about spontaneous intracerebral hypertensive hemorrhage associated on anticoagulant therapy? Okay, then I think the chances of expansion is very high in both the situations. Now, patients who are on antiplatelet, we develop hypertensive related ICH. The volumes, initial volumes are high and their chance of expansion is likely to be very high. Similarly, which is much more high in patients who have are anticoagulants. At least we can think of reversal of anticoagulation in patients if they are on oral anticoagulants, but still we don't have agent to reversal when they are on low molecular weight heparins.
Dr. Murthy, thank you very much for that very comprehensive lecture and very good discussion. Thank you very much.
So moving on with our next talk, it's on etiology and management of subarachnoid hemorrhage, and it will be delivered by Dr. Alex Georgiadis.